Is.
On the left side.
Welcome. Good afternoon, everyone. Welcome to the Appropriations Committee hearing. My name is Rob Clements. I'm from Elmwood. I represent Legislative District 2, which is Cass County and Eastern Lancaster County. I serve as chair of this committee. We will start off by having members do self-introductions, starting with my far right.
Myron Dorn, District 30.
Mike McDonald, LD5, South Omaha.
Tony Vargas, District 7, downtown in the heart of South Omaha.
Lauren Lippincott, District 34.
Steve Erdman, District 47.
Assisting the committee today is Tamara Hunt, our committee clerk. To my left is our fiscal analyst, Michaela Finley. Our pages today, Malcolm from testifier sheets. If you are planning on testifying today, please fill out a green testifier sheet and hand it to the committee clerk when you come up to testify. If you will not be testifying but want to go on record as having a position on a bill being heard today, there are white sign-in sheets at each entrance where you may leave your name and other pertinent information. These sign-in sheets will become exhibits in the permanent record after this hearing. To better facilitate today's proceeding, I ask that you abide by the following procedures. Please silence your cell phones. Move to the front chairs when you are ready to testify. The order of testimony will be introducer, proponents, opponents, neutral, and closing. When you come testify, please spell your first and last name for the record before you testify. Be concise. We request that you limit your testimony to 5 minutes or less. Written materials may be distributed to the committee members as exhibits only while testimony is being offered. Hand them to the page for distribution when you come up to testify. If you have written testimony but do not have 12 copies at this time, please raise your hand now so the page can make copies for you. And now we will begin today's hearing with LB 46, Senator Dorn.
It's Dorn Day.
Senator, you're welcome to open.
Thank you. Thank you, Senator Chairman Clemens and the rest of the Appropriations Committee. And no, I did not schedule these 5 bills at a time. So, yeah. I don't know why, but we are here and we're glad to have them all at the same time also because many of these, there's a lot of interest by similar type people back here and stuff. So thank you very much for doing this. My name is Myron Dorn, M-Y-R-O-N-D-O-R-N, and I represent Legislative District 30. I am here to open on LB 46. This bill would appropriate $250,000 to the Department of Health and Human Services for a Medicaid reimbursement rate study of home health care, skilled nursing services, and private duty nursing services. To remind committee members, home health is typically the lowest cost option that we have for delivering healthcare services to a wide range of Medicaid beneficiaries. There are members of the state association here to testify about that. I also believe that most Nebraskans prefer to receive as many of their healthcare services while remaining at home rather than being in a hospital or other types of facility care settings. There are types of skilled services that home health agencies provide, including cardiac care, respiratory care, physical therapy. Everything except surgery or maternity services can be provided in the home. But delivering those skilled services in the home for Medicaid beneficiaries required skilled caregivers. Most of the time, those skilled caregivers are nurses. We all understand that there is a nursing shortage in Nebraska and that competition among healthcare providers for nursing services exists. The testifiers behind me will speak to this in detail, but what they have conveyed to me is that they simply can't hire nurses to provide home health care services or anything close to what Medicaid reimburses for their services. The result of this is that many home health agencies simply don't take Medicaid referrals for home health services. In other words, the state isn't able to offer the cheapest form of care to many Medicaid beneficiaries because home health agencies can't hire the nurses they need for the reimbursement they receive. LB 46 is the first step in determining a solution to this problem. The bill asks for $250,000 for the Department of Health and Human Services so the department can hire a consultant to examine the home health, skilled nursing, and private duty nursing reimbursement rates for Nebraska Medicaid beneficiaries and determine whether they are meeting providers' annual cost of service. If the study shows that rates need to be increased, it would be a future decision for this committee to determine whether we want to appropriate the money for any future increases. Thank you for considering this bill. Be happy to answer any questions, but just a side note, when you look at the fiscal note, there's a line in there that says this study would most probably qualify for federal funds and that this could then be half federal funds and half general funds. So if you look at it that way, and if the study ends up costing $250,000, it's actually a $125,000 general fund request. So.
Other questions from the senator?
Thank you, Senator Clemens. Thank you, Senator Dorn. So if the study, it could cost 500,000.
That we don't know, yes. What we're asking for is 250,000 here. And then,
But it says
yeah.
50-50 match. So we're appropriating 250. And if the feds do 250, that's 500.
Oh, then it'd be 500. Yes, that could be also.
So you may not know the answer to this, but what in the world would take 500,000 to do a study? So even at 250,000, at $50 an hour, that's a significant amount. And you know what's going to happen when you put this up for an RFP and they already see that we've appropriated 250,000, how much think it's going to cost?
I will be honest with you and tell you, when we brought the bill, we thought the whole study was going to be $250,000, and that's what it was going to take. And that's what it should be bid out for. Now, after that, I don't know if we have much say or control.
If you ask for 50,000, I think that'd be a lot.
That would-
This is a exorbitant. We hear this every time, why it costs $250,000. If you want to add up somebody employed at $100,000 a year, that's 2.5 employees for a year.
And
That
then,
seems like a lot.
if there's extra money left over in there, I think we ought to be able to see where that extra money is at, or if it should come back to us. Yeah, I agree with you. Thank you.
Other questions? Just one.
Yeah.
I believe if you determine that there is federal cost share, we'd like to see an amendment
Okay.
here to with 125 general funds and 125 federal
Okay.
funds. But would you research that?
We will research that and have that ready for you when we start discussing bills. We will have that ready by then. Yes.
All right.
Thank you. No,
I
thank you for that.
will welcome proponents. First proponent come forward. Welcome.
Hi, my name's Carrie Edwards, Carrie Edwards.
Go ahead.
I'm the Director of Home Care at Mary Lanning Healthcare in Hastings, and I'm President of the Nebraska Association for Home Health Care and Hospice. Our association represents Nebraska's personal care, home care companies, home health agencies, and hospice agencies. We would like to thank Senator Dorn for introducing LB 46. Home health care is provided for Nebraskans ranging in age from infants to the elderly. Aside from delivering babies and performing surgery, home health agencies can provide a variety of skilled care and services in the patient's home and community. This includes cardiac care, respiratory care, disease management, wound care, well baby visits, the physical, speech, and occupational therapy for patients recovering from surgery, hospitalizations, or strokes. It is important to note that home health is the lowest healthcare cost option for patients to remain safe, comfortable, and independent in their homes. When you ask Nebraskans where they prefer to receive healthcare services and supports, a majority indicate they prefer to remain at home. Nebraska's home health agencies are partners with hospitals, skilled nursing facilities, assisted living facilities, behavioral health, social workers, and other professionals in the healthcare continuum. A key component in the value of home health services is the long-term cost savings to our state. Although it is difficult to measure what the number looks like, there are situations every week when home healthcare nurses intervene to help patients prevent and avoid emergency room visits and rehospitalization. In 2020, the need and demand for home health services was forecasted to grow by an anticipated 35% by 2030. Medicaid expansion in Nebraska and the COVID-19 pandemic added further to the growing need. In the past 3 years, Nebraska's hospitals have been at or near capacity and discharged patients to their home with more complex healthcare needs. Nursing facility closures place further strain on Nebraska's healthcare delivery system and has also contributed to the increased need for home health services so that patients can remain in their local communities. The COVID-19 pandemic created further challenges for home health agencies to offer competitive salary and benefits for nurses and other staff. Traveling nurses are earning at least twice the amount that home health agencies are able to pay. Hiring and retraining trained nurses to provide skilled nursing and private duty home health services has become very difficult. The handout we distributed reflects some initial analysis by an industry partner that has conducted reimbursement rate studies for home health care in other states. The handout references that the increase in Nebraska home health discipline cost per visit from 2020 to 2021, based on CMS cost report data, is 9.58% for skilled nursing care. It does not take into account inflation since that time, nor the rising cost of fuel for nurses to drive to patient homes. Our agency alone in Hastings recently decreased our service area to 40 miles effective March 1st due to the expenses being paid for staff's travel time, mileage, and the inadequate reimbursement rates. We previously served a 60-mile radius, serving parts of 13 counties, and reduced to now serving parts of 7 counties. Many of those counties we served previously will have no other home health care option. Our association has discussed with the Nebraska Department of Health and Human Services that it has been at least 20 years since a home health reimbursement rate study has been conducted. Our home health agencies have indicated that they have stopped serving Medicaid home health beneficiaries or have had to limit the number of beneficiaries they can serve. 2 years ago, an informal cost report review was conducted looking at a cross-section of Nebraska home health agencies represented rural and urban areas. That review identified Medicaid home health skilled nursing and private duty nursing as the areas with the largest gaps of reimbursement rates as compared to actual care delivery costs. We believe that performing a rate study is a more prudent and data-driven method for addressing these challenges. As part of the study, our goal will be to determine the true cost of care for home health providers in Nebraska. Home health agencies would be surveyed and asked to provide the amount spent in each of these outlier categories. This information will then be correlated with CMS claims and cost report files to determine total costs and expenses to deliver services. Often when Medicare and Medicaid rates are determined, they are not based.
Thank you. That's your time. Are there questions from the committee? Senator Wishart?
So what I'm understanding is that through your own analysis or through a consultant, you have done a rate study. I'm looking at this, that you do have a sort of a comparison to look at what rates should be.
There's other states that have done rate studies.
Okay, there are other states. So this is, you're utilizing the other states' information for
Yes.
this data. Okay, thank you.
Yep.
Other questions? I had a question about, 3 different types of providers, home, skilled, and private. Could you tell me what qualifications that differ between, what type of provider does those 3? Are they different?
Yes.
Does it have to be an RN in each case, or can it be other?
No. So the skilled home health care requires a skilled service for a nurse or a licensed therapist. That could be like the wound care that was mentioned, or disease management, education, IVs in the home. The private duty side, that can be a contract with a patient to get personal care and support services. Some of those require nursing. It depends on the agency and what they're licensed to provide for those members.
It didn't answer my question.
Well, I'm sorry.
Does it have to be a registered nurse in any of these?
You can have a registered nurse or an LPN
All right,
for the skilled home health.
in each of these three categories?
Yes.
Very good, thank you. Any other questions? Thank you for your testimony. Next proponent for LB 46.
Senator Clements and fellow members of the Nebraska Legislature Appropriations Committee. My name is Ryan Beathy, RyanBeethe. I'm the Director of Business Operations at Maxim Healthcare Services in Omaha. Testifying in Nebraska as well as Maxim Healthcare. Our members employ nurses, nurse aides, and therapists that deliver medical care and support at home for your Nebraska constituents. We're asking for support of LB 46, which would appropriate funds for a comprehensive Medicaid home health rate study. Home health agencies are struggling to compete with hospitals and nursing facilities for qualified RNs and LPNs because of the competitive pay facilities are offering compared to home health agencies. Home health care is the most cost-effective level of care for Nebraska Medicaid beneficiaries, but currently is the lowest funded, resulting in a lack of qualified staff. Currently, patients who are deemed ready to discharge home by medical professionals are having to wait months, sometimes even years, to discharge home because home health agencies aren't able to hire qualified nursing staff quick enough. At Maxim Healthcare, we specialize in caring for Nebraskans who need around-the-clock care. Most of our 130 Nebraska Medicaid beneficiaries are pediatrics who have ventilators, tracheostomies, and G-tubes. Without nursing support in the home, these patients would be forced into facility-level care that would also be paid for by the state, just at a higher cost. A competitive Medicaid fee schedule will allow Maxim and other home health agencies to attract qualified RNs and LPNs so these kids can be at home with their families and loved ones. At that, these are the kids that are born. They're usually at Children's Hospital for about 3-6 months, and that's when the doctors deem them eligible to go home. And then the process starts where the biggest delay right now is nursing. So if we can hire nurses at a higher clip, we can get them home, and then the cost savings, it's just that's really the smallest component, because you get these little kids home with their families, siblings. And we see it all the time where these kids are ready to go home, and the only thing holding them back is just the 3 or 4 agencies that provide the private duty nursing for these kids, that we just can't hire nurses quick enough. So that's where this rate study is going to show the rate increase that we need. So then basically we can get these kids home. It's crazy how many kids that we see just in Nebraska that are born each month that need this level of care. But most of them, you can picture it's a hospital setting at home. Mom and or dad, grandma, grandpa, they're the primary caregivers, and then our nurses are supporting them. We're confident this study is going to show the gap between current Medicaid fee schedules compared to the market landscape. The study is going to help the state allocate appropriate funds so home health agencies can hire and retain qualified caregivers so our fellow Nebraskans can remain at home rather than in facility level of care. Any questions?
Senator Wishart?
Ryan, thank you for being here, and thanks for what your company does for kids. The previous testifier said that there are other rate studies that have been done in states, and so they were able to show us some comparable sort of information on where we are and where rates need to be. Why not just use that other state's data and have the department just look at what other states have done? Can it be that different in Nebraska than it would be in another state for these types of services? Or do you want should I ask somebody else?
No, you can ask me. I've sat here and had this same testimony for years. And a lot of times there's just not the money to invest, right? That would be the easier approach, but that approach hasn't worked in the past. But the $250,000, and if the federal match would be $125,000 approximately, we filled in, it would be the concrete data showing how far off the rates actually are. So I guess to answer your question, in the past that didn't work.
Okay, but there are other states. Could we argue that would it be fair to say that other states' data could be used for us to look at for comparable needs in Nebraska?
Absolutely.
Okay, thank you.
Senator Armendariz.
Thank you. Thank you for being here. Can you tell me, does your company hire and provide traveling nurses, what they call traveling nurses to these facilities?
We don't. This is just home health care. So we hire RNs and LPNs that care for these kids that only live in Nebraska. So they could be in Kearney, Omaha, any small town, but we only hire nurses. We don't do any travel nursing.
Similar to what VNA?
VNA would do more of like, if you consider like the Medicare, I mean, they do all different fundings, but it might be like the acute need coming out of a hospital, maybe grandma broke her hip and then needing the 30 to 60 day help. These kids sometimes they come out of the hospital, hopefully at 6 months or a year, and they might have this level of care until a lot of times these kids do get their trachs out. So it might be 4 or 5 years old. These kids get their trachs out. They're going to school. We actually follow these kids to school too, and that's paid for by the Department of Education. If they get their trachs out, then they don't need us anymore usually. Obviously, if they pass away, sometimes these kids have this level of care for years.
Okay, so you don't contract with any organization. You are your own.
Yeah, we hire our own
organization
nurses.
that
We
you-
have 250 RNs and LPNs who work for us, and then they staff the hours for the 130 patients that we currently serve. And any hours we can't staff at the home, then the parents are to help out with.
Okay, thank you.
Does that answer your question?
Yeah.
Okay.
Other questions? Seeing none, thank you for your testimony. Next proponent. Good afternoon.
Good afternoon. So, Senator Clemens and members of the committee, thank you so much for having me today. My name is Sean Balke, spelled SEANBALKE, and I am president of private duty nursing for Pediatric Home Service. And of course, I'm testifying today in favor and asking for your support of LB 46. My agency specifically is a specialist in this area of service. We only provide service to the most medically complex, most sick pediatric children that need to come out of an acute care hospital or rehab hospital. And we do so, we're really the only agency that does so across the entire state of Nebraska. So we cover a very wide territory. So we see kind of what the circumstances, environments are in, metro areas like Omaha, and then, all the way out by Sydney, right? We get to see kind of everything across the board. And I want to thank Senator Dorn for introducing this bill. And I really would like to talk a little bit based on my peer's testimony. I'll deviate a little bit. We do only hire RNs and LPNs, and we do not contract with any of the traveling nurse agencies. We can't. They charge way too much with what we get reimbursed. There's no possible way we could make it work. And Senator Wishart, to the point that you brought up earlier, so my organization provides services across 10 different states. So we do see different environments, and we've seen rate studies in other states. The one comment I would say that Nebraska is a little bit unique. If you look at the demographic data and the supply-demand data for Nebraska, there are more RNs from a ratio standpoint than there are LPNs. In a very disproportionate ratio, right? So another state, for example, I provide services in Missouri. And in that state, the large majority of nurses we employ are LPNs and a small percentage are RNs. In Nebraska, it's a large percentage RN, small percentage LPN. So that's going to skew the data a little bit because Missouri has a blended rate, right? It's one rate doesn't matter if it's an RN or an LPN. In Nebraska, it's distinguished between an RN level, LPN level, high tech, low tech. So there are different ranges for those. So I could, and to your point earlier, Senator Erdman, you could take my word based on what our candidates are coming to. Like we get hundreds of applicants, and nurses are looking for alternative employment settings because they don't necessarily want to stay where they're at. And so I have data that shows here's what they're asking for. And in my testimony, it says, they're asking for exactly basically what we get reimbursed from the state right now. So we are, and to answer your question earlier, Senator Clements, we are a CMS certified home health agency. So we have significant cost and oversight to be able to be licensed and certified to provide this service. It's not an easy thing to get. So there is overhead. And we have to have funding to be able to support that. If we paid the nurses what they're asking for, we could not survive. It's impossible. So I could provide data that shows this is what it would take. We're trying to provide an informed way for the state to allocate funds to say this is what it would cost to adequately fund this rather than just using our data. I mean, we can do that, and I would be happy to supply that to the committee. But so that is one option, but I think a study would be effective in showing what it actually costs. The one point I will make is that we currently as an agency have 28 referrals. This is 28 medically complex children that are ready to come home. They've been ready to come home and they cannot come home. And this is to all different areas of the state because we cannot hire nurses. And the main reason we get rejected by candidates is rates, or pay rates. But we can offer them because they have options. So that just illustrates the point that it's a significant deal because these children are not, there's not a lot of them, but they're extremely complex and extremely expensive. So if we can't get them out of the hospital, and it's about $4,000 to $5,000 on average dollars a day in acute care. If we can't get them out of those settings and get them home to a much lower cost setting, you can start doing the math. We have cases that have been in the hospital ready to come home for more than a year, more than 2 years in some cases. So you add the number of days times that amount, you start to think, wow, that cost starts to make some sense why we might want to do a study and look at how we can pay appropriately. So with that, I think I deviated a little bit, but I wanted to hit on some of the points that were brought up in questions, and I'll be happy to stand for questions.
Other questions from the committee? Senator Armendariz.
Thank you. Thank you. So how would you anticipate you would compete with those traveling nurses rates?
We can't.
So
We can't.
health systems are even losing nurses to that.
Correct.
How would you think you could stomp that out and pay a normal nurse's rate?
That's a wonderful, wonderful question. We don't expect to compete exactly with traveling nurse jobs or even with acute care like Children's Hospital, for example.
Mm-hmm.
Home care nursing is unique. There are pros and cons to it, right? A nurse that wants to work in home care, they typically want to do so because they get to work with one patient instead of 12 on a given shift. We have flexible scheduling. They can help kind of change their hours and flex their hours in a way. They get to work in a home setting rather than a hospital setting. So there's kind of like these features and advantages of the job that make it something that a nurse would say, I can, instead of making $50 or $60 an hour in a hospital, I can come work for you for a fraction of that, but not $20 an hour, or $25 an hour. So they're willing to take a cut in compensation to come do this work, but not the extent that they're being asked to take now. So we have to get closer. We're never going to match those rates, but we have to be able to at least be competitive for maybe 50% of the nurses that are out there that are willing to do this work. So we're trying to get there.
Have they told you what they want?
Yeah, in my testimony, I don't know if I hit it. I apologize if I didn't. Our rates are ranging anywhere from the upper 30s to the mid 40s right now. That's what we get reimbursed from the state. So that's what's being asked for. They're asking for the 30-ish to low 40s
By these
in most
nurses.
cases. Mm-hmm.
So if we already know, why do we need to study?
I agree. I mean, we have data. We can
Okay.
present data as an agency.
Fair enough.
I know my counterparts could as well, to say we can look at what our recruiters and what they're telling us that candidates are asking for. And so that certainly is one way. Our mindset was we want to provide a way for the state to make an informed decision based on data. I'd be happy to provide, I have hundreds of examples of candidate requests that I could provide. So that would be an option.
I appreciate that.
Okay.
Thanks.
Sure.
Other questions? Senator Erdman?
Thank you, Senator Clements. Thank you for coming. Your last comment stirred a question then. So if you can figure it out, what it should be, why does it cost $250,000 for somebody else to figure it out?
I do not disagree with you.
Okay, so here's my analysis, right? $250,000 at $100 an hour. That's 2,500 hours of work, right? 2,500 hours divided by 4 people is 625 hours, or 15.6 weeks. 4 people working on this for $250,000.
Right.
And you just described pretty explicitly and simple how you figure out what you should pay. I have no clue why we have to spend $250,000 to discover what you've already discovered.
Yeah. I would agree with your sentiment. I think that if agencies can provide data that the committee would feel is valid and is accurate, there would be no need for that study.
Right.
I think the association's intent was to provide a method so that we wouldn't just come to you and say, please take our word for it, that we have a way to validate that.
I'm not opposed to a study.
Yeah.
Okay. I'm not opposed to having people getting paid more. So we have people
Sure.
that need to do the job.
Sure.
My point is we continue to get these that are requesting exorbitant amount of money
Mhm.
and I never figure out for what.
Sure.
That's my point.
Sure.
Thank you.
Other questions?
Okay.
Senator Wishart?
Would there be a way for your agencies to come together and at a dollar, maybe not later on, of what we would need to do to get you at that competitive level?
In my opinion, the answer is yes. I think there's a collaboration between agencies is really good in Nebraska. I think there's mutual shared interest. No one's asking for anything different than what, Ryan with Maxim provides the exact same service that my company does. So we want to work together to make sure that these kids and families have these options of care. So I think that's absolutely a possibility.
And second question is, could you get that to us by the next week?
In the next week?
Yep.
I could, my agency could, yes.
Okay, thank you.
Yes, I can't speak for the others.
Other questions? I had one question.
Yes.
Do you know what percent of your patients are Medicare, Medicaid, and private percentages?
Yeah, large, over 80 to 90% Medicaid, and then the rest there's going to be some commercial insurance, and there's no Medicare.
No Medicare?
No.
All right. Well, yeah, you're a pediatric home
Correct.
service center.
Correct. Yeah.
Very good.
Yep.
And you are a member of the Home Health Care Association?
Yes, correct.
All right. Very good. Thank you for your
All
testimony.
right. Thank you so much.
Are there other proponents for LB 46? Seeing none, is there anyone here in opposition? Besides Senator Erdman. Sorry, I apologize. Is there anyone here in the neutral capacity? Seeing none, Senator Dorn, you're welcome to close.
Thank you. Thank you for the hearing there, but I also want to comment one to Senator Erdman. This comes more from a lifelong learning process. We had a neighboring feed yard about 20 years ago. They needed to have a permit because they had the lagoons and stuff. They need to be certified by the state. The owner, he wrote it out. He wrote the specs out, exactly what was required, turned it in, and they said you needed a stamp. You needed an engineer stamp. They went and went and talked to an engineer. It was going to cost $12,000, and they said, no, they're not going to pay that. So he rewrote some of it, turned it in, still didn't qualify. So then they told him, without that engineer stamp on there, we won't pass it. So they went and paid the $12,000 to the engineer. He read over the thing, changed about 3 lines in it, submitted it, it got approved. So that's part of when you talk about cost, sometimes there's costs that we, the legislature, sometimes probably have a part of imposing. So thank you.
Yep.
Take any questions,
Any
I'll
other
do
questions?
otherwise.
Thank you.
Seeing none, thank you, Senator Dorn.
No.
And we have position comments for the record. 5 proponents, no opponents, and none in the neutral capacity. And that concludes the hearing for LB 46. We'll now open the hearing for LB 128. Senator Dorn.
Thank you again. Good afternoon, Chairman Clemens and members of the Appropriations Committee. My name is Senator Myron Dorn, M-Y-R-O-N-D-O-R-N, and I represent District 30 in the Nebraska Legislature. I'm here today to introduce LB 128, a bill to increase the rate paid to Nebraska's hospitals when providing inpatient or outpatient care to Medicaid patients. This bill will increase the Medicaid provider reimbursement rate to 9.6% in July 2023 and 7.7% in July 24. Hospital costs are rising. Workforce costs have risen 26.8% since 2020. Medical supply costs are up 25.4% and drug costs have risen 42.5%. But reimbursement for patients on Medicaid have not kept up. with the average loss for Medicaid care of 60%. Last year, this committee and the full legislature increased reimbursement rates for a number of Medicaid providers, giving many providers a much-needed 15% increase. However, no additional increase was given to hospitals at that time. Instead, in 2020, 2021, and 2022, hospitals received just a 2% increase, well below the actual increase in cost to provide services. This bill is intended to allow our committee to discuss the appropriate rate increase to be included in the budget as we move the budget forward. As we know, the governor's budget did not include any Medicaid rate increase. There will be those behind me with more information as to the consequences of moving forward without any increase, and the importance of our committee determining what rate of an increase we should provide and why 9.6% and 7.7% may be the right amount. I'm offering an amendment, which you will see here on the next page in your handout, to include physician clinic services. We missed this during the drafting stage of this bill. Thank you, and happy to answer any questions. Also, will note that we've had several visits with some of the people from Bryan Hospital. They did include some of their information. I did ask them to include some information about what their Medicaid reimbursement and what their dollar amounts and some of the losses that they are and stuff, and then another article there. So I'd be happy to take questions.
Any questions? Seeing none, we'll have the first proponent.
We'll be back up. Yeah.
Right. Welcome.
Good afternoon, Chairman Clements and members of the highly esteemed Appropriations Committee, maybe the most esteemed committee in the legislature. I am Jeremy Nordquist, Jeremy Nordquist, President of the Nebraska Hospital Association, here today representing Nebraska's 92 hospitals and 50,000 hospital employees. We strongly support and thank Senator Dorn for LB 128. This is absolutely critical to preserving hospital services across the state of Nebraska, especially in rural communities. The first slide I have on the PowerPoint coming through will give you numbers on what's happened with our costs during the 2 years of COVID, our current year, and projections, our best projections that we have available for the next year. During fiscal years 21, 22, which would basically be the 2 years of COVID, we saw a combined 20% increase in that time period. In the current fiscal year that most of our hospitals are operating in, our CFOs are reporting a budgeted 6.1% increase in costs. And then our CFOs gave us the best numbers they could, looking at what would be the second year of this biennium in the future, and they project about a 4.2%. Good news is the rate of growth is coming down. The bad news is the growth is still growing substantially. So if you compound the 2 years of COVID, where we are this year and where we project to be next year, you're looking at, over those 4 years, a 32.8% cost increase in hospital services. That's how much the cost to provide healthcare has gone up. The third page has why we came up with 9.6. And as Senator Dorn mentioned, we received a 2% year increase in each year of the last biennium. We took those percentages from our CFOs, the 6.1 and 4.2, and we said, well, we can't continue to carry the heavy load that we lost in the last biennium without any makeup on that. So we really thought hard, what would that be? And it landed at 3.5% a year additional adjustment. When you compound the 2% with the 9.6 and 7.7, that gets you to 22.8%. Again, our costs during those 4 years would have grown 32.8%. So we would still be 10% below where we were with provider rates going back to the beginning of COVID. The graph shows you a 21-year history of provider rates compared to hospital costs. Never before has the legislature enacted a zero or negative provider rate unless we're in a state budget crisis. So a 0% would be certainly out of the history of provider rates. The average cost over these 21 years of hospital care grew 5.6%. That's a fairly big growth, but it is over 1% below the national average of growth during that time period. But our provider rates in Medicaid, the average annual increase was 1.56%. That is why, if you turn to the next page, we see Medicaid reimbursements for services that are so far below the cost of providing care. A hip replacement in Medicaid costs, and these are audited costs that are submitted to CMS on cost reports, $23,400, and we are getting reimbursed from Medicaid only 38% of costs, or $8,800. So what's that mean for hospitals? The growth of costs certainly has been the biggest factor in tough bottom lines for hospitals. It means services are being reduced, and we already saw it in 2022. We lost, you'll see the list of services: inpatient geriatric psych unit in central Nebraska, nursing homes in northeast, southwest, and north central Nebraska, orthopedic and nephrology services lost in north central Nebraska, obstetric services in southeast Nebraska and west central Nebraska, home health services eliminated in northeast and north central Nebraska. A long list of services that have been cut already, and hospitals will continue to have to make those changes. Lastly, I just wanted to, there was some muddying of the water on provider relief funds, the money that came in from the federal government. All of that had to be utilized for two purposes: COVID costs or lost revenue. Most of our hospitals had to use it for lost revenue. One hospital system alone, when the state shut down services 3 times over a 2-year period, lost $340 million of revenue. They got $80 million in total provider relief funds from the state. So those federal funds didn't even make up a quarter of the lost revenue they ended up having. Those funds have all been expended, and all of those reports are public documents that have gone to the federal government. So if anyone has any follow-ups on those, happy to answer. Thank you.
Other questions from the committee? Senator Erdman.
Thank you, Senator Clemens. Thank you, Mr. Norcliffe, for
Yeah.
being here. On the fiscal note, can you tell me how the determination is between the state's contribution and the federal funds? Is it a percentage, or how do they figure that?
Yeah, so it depends on the population mix, and the department would utilize the data working with the fiscal office. So if it's, the expansion population, every service we're providing to that population, the federal government's picking up 90% of that cost. If it's for a child, the federal government's picking up about 70% of the cost. If it's somebody who was already the disabled population or other populations, the federal government is closer to a 50-50 mix. So it depends on the population mix, but ultimately it comes out to almost a 2-to-1 federal match on those, roughly on those dollars. So every dollar the state would put in general funds for provider rates, $3 would go into local economies to pay nurses and the healthcare workers at our hospitals.
So are these federal funds, is that ARPA money?
Nope, that's just the Medicaid match.
Okay.
That is in statute and will be in statute until Congress changes the law.
Thank you.
Yep.
Other questions? Speaking of the fiscal note, I assume it does not include the physician clinic services.
That's right.
Is that right?
Yeah. Yeah. Yeah, so the department.
Does not include emergency room or dialysis either.
Yeah, so if you look at the second, Michaela filled me in, if you look at the second page of the fiscal notes, the department's estimate did include dialysis and emergency room. Those should have been spelled out in the bill draft initially. So as the committee makes this consideration, we certainly would want to make sure emergency room is treated the same as for increase as other the inpatient and outpatient hospital services.
Okay.
Yeah, you may need to get some new numbers from the department on the physician clinic side.
Okay. Excuse me, I need to make
No,
a note.
that's all right.
Do you know in your association what your Medicare, Medicaid, and private pay percentages are?
For the association as a whole, I don't have that number, but I can tell you I have a list of it for every hospital. And the vast majority of our hospitals fall in between 60 and 80% Medicare and Medicaid together. Medicaid is certainly the smaller part of that. It can be as high, as 18, 19% for a very high Medicaid hospital. It can also be single digits. But in general, the average, the most hospitals in our state fall between 60 and 80% government paid. And if you're interested, the Medicare increase for the year overall is 3.8%, but there's a factor on that for wages. And because we're a lower wage state, that gets ratcheted down. So our increase for hospitals for Medicare for this year is 3.2%.
And Medicaid expansion is winding down. Have you analyzed how that's going to affect you?
We've certainly talked to the department and had a lot of conversations with them about the process. I think if people come in for services, our hospital social workers and support teams do what they can to check to see if they're eligible for benefits. So if they fall off now, maybe they requalify in the future. At the end of the day, because I hate to say it this way, but because we lose dollars on Medicaid patients, you don't make it up on volume when your margins are negative per case. So, we certainly want people to get access to coverage and be covered, and we will help them enroll in Medicaid. That's certainly better than having them be uninsured. But in terms of the fiscal impact, it isn't, having more people on Medicaid isn't a net plus for hospitals. So.
All right. Let's see.
Not expansion, but the redetermination is happening.
Medicaid expansion is here to
Yeah.
stay. I'm sorry.
Right,
Yes,
right.
Ryan.
Right.
The
Yep.
public health emergency.
Yep.
You understood
Yep.
what I meant.
Yeah, absolutely.
Thank you.
Yep.
And I believe that's all the questions we
Okay.
had. Anybody else?
Always happy if anyone has any follow-ups with specific questions. And we have a few hospital folks to talk about their specific situations. Thank you.
Thank you, Mr. Nordquist. Next proponent.
Good afternoon. My name is Pat Connell, Patconnell. I serve as the health policy advocate for Boys Town National Research Hospital. I've been a long-term member of the Nebraska Hospital Association Public Policy Committee. I was asked to testify today to talk about the history and the parallels between what we had in the late 70s and early 80s with inflation and how it impacted hospitals and healthcare. I've been in healthcare for 45 years now. I didn't start when I was 16. I did not, but I've been in administration for over 45 years. There's a lot of similarities. I put a graph on the top of the page, the bottom of page 1. It shows the inflation rates for that period. We breathed a sigh of relief after 10% in 1975, creep down to 5.7, and then it really took off. And we had 11%, 13%, and then another 10%. The biggest problem we had is that a lot of people were in denial of inflation. They thought it as a transitory phenomenon, and then they didn't understand the cumulative effect of inflation on cost and revenues and et cetera. If you go to, so if you look at this deal with inflation, hospitals had really only 3 options in order to be able to respond to this. Well, actually 4. The 4th one we don't talk about. That is, we cost shifted to the commercial insurance industry because what happened was Medicaid did not keep up. We got very small increases in Medicaid and we had bigger increases in inflation, so we had to make up for the difference. But the 3 major things that hospitals did was, one is we tightened our belts and we cut cost. And we have this has become a culture for hospitals. There's not cost anywhere that we can just come back and say, tighten your belt, make up the 20% of inflation by cutting costs. The second thing that we did is that low margin programs that required a lot of subsidy by hospitals, those were the first ones to go. And the rural hospitals were the most fragile. They had a lot of programs with very low margins. So what ended up happening is those hospitals closed programs or reduced capacity. Well, then the people in those rural areas said, hey, I need to go for healthcare. I call my hospital or I call my clinic and I find out I have to wait 6 to 8 months to get an appointment. Meanwhile, at the same time, the urban hospitals are doing the same strategy. They're cutting programs. They're reducing the size of those programs. They're doing this quietly. And those patients from the rural area are now trying to come into Omaha and Lincoln to gain appointments that they can't get out in central Nebraska and western Nebraska. So what ended up happening is things would be pushed out 6 to 8 months. I have some really good ranching friends of mine in Valentine, Nebraska that called and begged me to help them find a cardiology appointment in Omaha for their father. And I asked, well, what do you hear? 6 to 8 months before they can get in for a consult. The third thing is that we start to see hospitals and clinics close. They reduce the number of clinic locations, so patients had to travel farther. And one of the other things that hit the rural community was instead of having to drive 50 miles or 100 miles for an appointment, they had to drive 300 miles. So to get to your doctor, you had to waste a day going there, seeing your doctor, and then waste a day getting back to there. So you lost 2 days of work. The last thing is that I detailed out on one of the last pages, the hospitals that took dramatic action in the Omaha area. I can't call the hospitals that closed down in the rural areas, maybe somebody else can. But the problem with the inflation was it was a cumulative effect. And so for instance, St. Joe's Hospitals and St. Joe's Center for Mental Health, they had to sell out to American Medical International because they only had 21 days in cash on hand. That was a program that was disproportionately taking care of a lot more Medicaid patients. But all these hospitals and programs that are listed in these bullet points had to have a significant either close or they cut their programs and services. So the last two things I would leave you with is you can't kick this thing down the road. It just ain't going to work. You got to take some action now because that inflation of 20% is going away, those cost increases. You're going to have to do something to make up for it. And then the second thing is healthcare is an investment and it's local. And talk to your people, they'll tell you healthcare is a local and it's an investment. You can't get people to come and move to Nebraska and take a job if they not going to get the level of care that they think they need to get for their family. So I kind of gone through that rather quickly. I appreciate this opportunity to talk about what happened 45 years ago or 40 years ago, but there sure is a lot of parallels.
Thank you. That's your time. Are there questions from the committee? I had one question I forgot to ask the previous person. You've given us some cost study information about the association. Did it cost you $250,000 to get it?
No, but later on today, I'm going to be talking about another bill about rebasing of behavioral health inpatient, and I think I'll have some good answers for your question at that time, so stay tuned.
Thank you. And I'll ask maybe Senator or Mr. Nordquist later. Thank you for your testimony. Oh, Senator Dorn.
When you talked about rural hospitals, what's your definition of rural hospitals, or where would they be located?
I think of rural hospitals as anything outside of Omaha, Lincoln, and some of the major cities along the I-80 Beltway. I-80 interstate.
Are those reimbursed any differently than hospitals in Omaha that you consider non-rural?
Yes, they are, but I think one of the speakers after me can better qualified to answer that question.
All right, thank you.
Other questions? Thank you for your testimony. Next proponent for LB 128. Welcome.
Thank you for the time today. Good afternoon, Chairman Clements and members of the Appropriations Committee. My name is Patrick Avila. That's P-A-T-R-I-C-K-A-V-I-L-A. I'm president and CEO of Merrick Medical Center, located in Central City, Nebraska. Merrick Medical Center is part of Bryan Health. It's a locally owned and governed Nebraska hospital system. We believe in keeping healthcare local, banking with local banks, and investing in communities to ensure that rural Nebraska continues to thrive. I've been working in healthcare administration for more than 20 years. I come to you today on behalf of the Nebraska Hospital Association and the Nebraska Rural Health Association in support of LB 128. Our hospitals are the lifeblood of our local communities, often serving as one of the largest local employers and providing quality care close to home. For every dollar invested in rural hospitals, $2.30 of economic activity is generated. Concurrently, projections place between 2 and 6 rural Nebraska hospitals are at risk of closure over the next year. When a patient in rural Nebraska comes to their local hospital for care and is deemed in need of a higher level of care, they are transferred to one of Nebraska's tertiary care centers. If patients are not able to transfer to this next level of care, or that care is delayed due to further travel, their care may be negatively impacted. At Merrick Medical Center, our patients can quickly be transferred to Grand Island Regional Medical Center or CHI St. Francis for this higher level of care. If those hospitals close service lines, if they reduce bed capacity, or they close altogether because of financial constraints they're under, the patient's next option for a high level of care is coming to Lincoln or going to Kearney, which is more than an hour either way. For patients in Scottsbluff and Alliance needing a higher level of care, the distance and impact can be even greater. A healthy healthcare system in our state is reliant on every hospital, from critical access hospitals to large metropolitan medical centers, being reasonably reimbursed for the high-quality, life-saving care they provide. The cost of providing care continues to rise as prices of supplies, drugs, and staffing increases. The Bryan Health System continues to see the proportion of commercial to government insurance shift to a majority of government insurance. In 2022, Bryan Medical Center relied on 29% of patients who were privately insured to cover the gap for the 71% who are covered by Medicare and Medicaid. This is a tax on every business and privately insured person in the state of Nebraska. Increasing provider rates is essential to our ability to care for Nebraskans of today and Nebraskans of the future. If rates remain where they're at, hospitals will close and services will be reduced. This is bad for every Nebraskan. I want to thank you for the opportunity to share the importance of provider rates for the health of all of Nebraska's hospitals. As you hear from myself and my colleagues today, I ask that you move to take action in support of LB 128. Friends and neighbors that we mutually serve are relying on you to ensure their access to health care. Thank you for your time, and I welcome any questions.
Are there questions from the committee? Senator Lippincott.
How short-staffed are you folks, Brian, in general, on nurses?
I know as a system, it's something that we continue to talk about. So it's a significant reliance on contract staff. I don't have the number for the whole system. I can tell you for Merrick Medical Center right now, and we have 120 employees. 8 of those employees are contract staff. So that's about 6% of our staff is we're relying on travelers to support that need.
And how much do they get paid more, or do you pay the agency?
You look at 2 to 2.5 times the salary of those employees, sometimes more. Yeah, it's a significant expense. So for us right now, our volumes are up. Our ER volumes are up almost 20% this year. Our inpatient or swing bed volumes are up probably about 18%. And our outpatient demand is up. So we really don't have an opportunity to cut for our community. There's not floors that we have in our critical access facility that we can shutter and continue to provide that care. So it's just basic services to our community. But yeah, about 6% of our staff is travelers.
And also, what's the vacancy or the occupancy right now of the hospital?
We, as a critical access hospital, we vary. Multiple times just this month alone, we've had more patients needing a licensed bed than we have licensed beds. We do try to transfer those patients when we can. What we hear back from our community when we do transfer, oftentimes they're in a gurney in an emergency room waiting for a bed at that facility. So we feel like we can offer better care closer to home for those situations. However, based on our bed licenses, we usually hit a reduced rate, or we're not getting reimbursed for keeping those patients if we need to keep them in our hospital for that care, and we're exceeding that. So we've had a total of, I think, 4 days just this month where we've exceeded that capacity.
And one additional, what is the percentage of people that come there and use Medicaid services versus not?
For Medicaid, we run about 15%.
15?
Yes, sir.
Other questions? Senator Erdman?
Thank you, Senator Clements. In your testimony, you mentioned somebody from Scott Buffalo line that says a long ways to travel. Those people in my area, they're not going to Kearney. They're going to Colorado. Because it's 200 miles to Denver, and it's almost 275 to Kearney. So we don't, the eastern part of the state may get those people, but the western part of the state, we go south. We don't come there.
Right. And the point, I think that's a great point. So thank you for that. The point is that's a long ways to go for care. And so depending on your ability to get there, the timing to get there, that can impact your ability or willingness to go to that next stop.
Yeah, it's easier. Of course.
And I know there's a lot of reliance on air flight to get to those locations, which in itself is a very costly endeavor.
Say none. Next pro. Good afternoon, sir.
Afternoon. Chairman Clements, members of the Appropriations Committee. My name is Derek Vance, DEREK VANCE. I'm the president of CHI Health St. Elizabeth Hospital here in Lincoln. And I'm representing the CHI Health and Nebraska Chamber of Commerce and Industry in testimony today. I appreciate the opportunity to express support for LB 128. In my 24 years of hospital administrative experience, I've experienced many times in healthcare. Recently, the COVID-19 pandemic pushed our staff and capacity to the brink. Yet we've remained steady in our resolve to care for our communities. Central to our mission is caring for those who are vulnerable, which in our case is nearly 1 in 5 patients that come in our door, about 19%, which through Medicaid services. Hospitals in Nebraska, however, as you've been hearing, are facing some of the strongest financial headwinds in decades. Our hospitals cannot weather the current inflation crisis without adequate payments from public programs like Medicaid. The reimbursement for 2023, Centers for Medicare and Medicaid Services increased the Medicare inpatient payment rate to 3.2%, or by 3.2%, and the state of Nebraska increased Medicaid reimbursement 2%. So as a result, Nebraska hospitals will receive minimal payment increase while costs have soared, as you've heard, over 20% in the last 2 years. So from fiscal year 2020, costs are up 27.4%, reimbursement is up 6.1%. It's in this context that we find the proposed state budget very concerning. Currently proposes, of course, no increase in Medicaid reimbursements to providers over the next 2 years, which would place the healthcare community even further behind. We know that you have many interests to consider when compiling the state budget, and we aren't trying to compete with those interests. We do request that healthcare providers are given consideration so that we can maintain the partnership that we both count on to care for the well-being of Nebraskans throughout our state. Hospitals are the anchor in many communities, providing well-paying jobs and providing essential healthcare to the residents who choose to live, work, and raise their families in Nebraska. We're proud of the fact that we cared for over 187,000 Nebraskans on Medicaid just last year. We will continue to do our part to reduce expenses and cut costs through sound financial practices, but we need your partnership to continue to prevent direct impacts to access, service delivery, and patient care. We welcome the opportunity to work with this committee, the governor, and our partner health systems in ushering reasonable Medicaid rate increases that will allow our health systems to keep caring for our communities. Thank you, Senator Dorn, for introducing the bill, and to the Appropriations Committee for your consideration. Happy to answer any questions that the committee has.
Other questions from the committee? Seeing none, thank you for your testimony. Next proponent. Welcome.
Thank you, Senator Clements, and thank you for allowing me to speak today, and also for the committee as well. I want to thank Senator Dorn for introducing this bill on behalf of hospitals. My name is Chad Van Cleve, spelled CHADVANCLEAVE. I am the CFO and Vice President of Finance at Columbus Clean Hospital in Columbus, Nebraska. I have over 26 years of healthcare experience, half of that being with a Medicare fiscal intermediary. I used to do the Medicare audit and reimbursement, and the other half has been on the provider side. What I've been passing out today is my testimony today is to kind of give a quick overview of how the recent inflationary times has impacted our hospital. Our hospital is a 50-bed facility, nonprofit, located in Columbus, Nebraska. We have over 52 physicians, active medical staff. Standing behind me today would be 930 employees, physicians, clinicians, people who support our staff, and also for our clinics in our community, they're also independent. We have over 230 volunteers. Our primary service area is Platte County, Nebraska, but we also have a secondary market, including Colfax, Butler, Polk, Nance, and Boone counties. We have a 24/7 level 3 trauma center in our community, which is important. I think the key thing is what we want to provide today from a Columbus Hospital standpoint. We retired our debt in 2012. We're rated in the nation as one of the top 20 hospitals for rural and community hospitals, and those are based on 8 metrics: inpatient market share, outpatient market share, quality, outcomes, patient perspective, cost, charge, and financial efficiency. So what you have in front of you as it's being passed out on the first page would show our last fiscal year, which ended in April of 2022. That was a full 12 months. Our net operating revenue that year was $128 million. Our net operating expenses was $119. That was an $8.7 million net income of a 6.8% margin. Again, we prided ourselves over the years of this simple methodology. You take care of your physicians, you take care of your staff, they will in turn take care of your patients, and the financials usually take care of themselves. What we've seen in 2023, 10 months in through February, is that we've seen a significant decline in the net income of our facility. That impact has been solely from the fact that our inflationary costs to both labor and our supplies and purchases items has brought us down to a 0.1% margin, and on $114 million, almost $115 million so far this year, $131,000 net income. That comes on the heels of an 8% increase last year of our charges, and another 8% mid-year that we implemented January of 2023, just to get ourselves above water. This was the first time in my 14 years that we've ever had a negative margin up to this point. What I want to point out, I think is important as well, is that operating expenses, I think people look and drive by our hospital systems and say, where's all the money being spent? If you look at at least I can speak to us, is depreciation and amortization. That includes all of our buildings, all of our major medical equipment, is 7% of our total operating budget. 1% being utilities, but about 63% of that, and the majority is spent on people, our labor. The men and women that come to work each day that care 24/7, 365, morning, night, to care for the patients in our community. I know it came up before, I put it in here because I knew it'd be a question, is the number of employees. We have 707 FTEs. Currently today, we do have travelers, 13. It's about 1.8%. I think we're probably one of the lowest in the state for travelers, and our expense shows that as well. One of the main reasons we've been able to keep travelers so low is because of our ability to pay, attract, and our culture to keep nurses in our community. On the next page, you're going to see our statistics. I want to at least point out, you can see this is a 6-year look back based on the first 10 months of fiscal year, and it goes from left to right. I want to basically show that we have not seen a decrease based on the number of statistics and our volumes going down. Last but not least, I want to show the financial position up until this point, 14 years running until 2021. Our average price increase was 4.39%. In the last 3 years, we've actually raised that price 8%, 8%, and 8% to make up for the shortfalls on our commercial payers. Those are self-funded plans. Those are individuals out in the community paying commercial, and those are individuals that don't have health insurance at all. And we are proposing another 8%. Cumulative, that will be a 36% increase in the matter of 3 years onto the backs of the consumers. The last slide, I'm going to skip ahead because my time's running short, is that the state of Nebraska actually calculates out what our Medicaid shortfall is. We actually submit information to qualify for special payment under disproportionate share adjustment. We've received that adjustment, at least in my history, since 2008. This last year was $6.8 million in uncompensated care. And I think on the last page that I have in front of you, you can see from 2008 it was a 1.7% or $1.7 million shortfall. That shortfall has increased to 6.8 million over the last 13 years. More importantly, we are taking care of more and more patients under the Medicaid expansion, but you can see the percentage is 36% of uncompensated care has now grown to 55%. That's a 20% increase. So,
All right, that's your time. Other questions? Senator Vargas.
Just wanted to give you the opportunity to finish your thought. I didn't know if you had any more that you wanted to say.
yeah, what I want to say is that, and with respect to the NHA for our hospital, a 9% increase next year and a 7% increase doesn't get us closer to covering the cost of our salaries and wages. If you think back, 63% of what we spend is on our labor. And right now, as of 2021, the last year was audited by the state of Nebraska, they are reimbursing 45% of our cost of care for our Medicaid patients. 85% of the inpatients that we see in our hospital, we have twice as many inpatients than any other hospital, or the average in the state, is related to birthing service. This is basically most of the inpatients that we see is OB. And I know that was asked for me to say, well, what services would you give up? What would you cease to provide? And I hate that question because of the fact that we don't want to see any of our services decline, and definitely not OB, but that would be where most of our Medicaid losses are seen. And I presented in the packet, I gave you a copy of our calendar. We do this as kind of from our marketing department. Does a great job. But it also is to reach out to our community. And I wanted you to see it as well. When we talk about Columbus Community Hospital, I know that the other hospitals can speak to this as well. It's not the building. It's not the equipment. This is Columbus Community Hospital. It's the people, it's the men and women, it's our physicians, our nurses, our clinical staff, our support staff that are there 24/7 waiting for our community who needs us in a time of need. And if I could, one personal story, I was there working late one night. I as a CFO, I'm in my office usually working with numbers, but I heard the call over the rate or the intercom, and it was code blue Broslow. It's not a common code. It's a pediatric cardiac arrest. And so I went downstairs, and one of our house supervisors has already responded to this. It was a child, a 2-year-old child, that had been brought in by their mother to one of our off-site, on-campus locations. That nurse proceed to deliver CPR to save that child's life. Unfortunately, the child had brought in, it was already too late. What I witnessed is something that you probably have heard about, but until you actually see it physically, the amount of delicate, the physician, the nurses, the social workers that had to work with that family as the father came in and as the grandparents came in and as the relatives arrived. It went from what I saw is extreme grief and sorrow and wailing to where you couldn't even pick them off the floor, to a moment of anger and misunderstanding that their child had died. I think with the piece that was missing is not just the technical skills that is made available through these highly skilled individuals in our ER, but also the house supervisor. Because that house supervisor, what I witnessed is that her first call was to her husband, and she brought in her 3 kids just so she could give them a hug for about 3 to 5 minutes until she had to get on with her the rest of the day. I think that's the piece that's missing in a lot of this, is that we can look at numbers. You can have the bald, CFO come in and talk to you about losing money. But in the end, what I'm advocating for is this increase in Medicaid spending is necessary for the frontline technical skilled workers.
All right. Thank you for that story. Senator Vargas?
I was just going to say thank you. And I have been to your hospital because my family members have been there. So I visited them when they were receiving care. So I just appreciate you coming.
Yeah, thank you.
Thank you for your testimony. Next proponent.
It's the doctor of the day today.
Welcome.
Thank you. Chairman Clements and members of the committee, my name is Daniel Rosenquist, DanielRosenquist. I'm a family physician from Columbus and the current president of the Nebraska Medical Association, which represents nearly 3,000 physicians in the state. The NMA supports LB 128. A significant increase in reimbursement for hospital services is greatly needed. These facilities are vital to the health of Nebraskans, and many are struggling to continue to provide services that Nebraska can't afford to lose. The focus of my testimony today is on the need for an increase in reimbursement rates for physician clinics. I want to thank the Nebraska Hospital Association and Senator Dorn for supporting an amendment that would add physician clinic services to the reimbursement rate under LB 128. Physician clinics across the state are facing many of the same increases in costs that you've heard about today from our hospital partners, including increases in staff wages due to the competitive labor market, increases in supplies and other expenses. The significant increase in costs is not just anecdotal. NMA surveyed a number of independent physician clinics to get a sense of how their operating costs have increased since 2020. And what we've seen is that staffing costs have increased 17%, supply costs 25%, and insurance costs another 15%. While the cost of operating a physician clinic have seen a significant increase, net patient revenues have simply not kept up, and in some cases have decreased. Physicians saw a 2% Medicare payment reduction for 2023. Meanwhile, increase the Medicaid rates for physical health have been slow. The incremental 2% increases came up 2 years with no increase. These increasingly thin or negative margins disproportionately affect small, independent, and rural physician practices. When reimbursement rates do not keep up, what you see is physicians limiting the number of Medicaid patients they can take in order to stay viable. It is common to hear about access to care issue for Medicaid patients for this very reason. Recently, here in Lincoln, there was no pediatrician clinic willing to, south of O Street, accepting new Medicaid patients. As physicians practices limit the number of medication care and minor illnesses, resulting in increased costs and further fragmentation of care. Increasingly, we see clinics interested in moving to a direct primary care model due to these payment challenges. And while these may be an attractive option for physicians who choose to cut out third-party payers, this further limits access to care for individuals on Medicaid. Finally, we see consolidation, private equity, and an absorption of clinic by health systems as it becomes increasingly attractive to move to an employed and salary model. This may help some clinics stay viable, but it also reduces competition and has some concerns about the increased costs of healthcare. In 2022, researchers at the University of Nebraska Medical Center reported that 25 out of 93 counties either have no family physician or have physicians that have more than 2,000 individuals under their care. When reimbursement rates are low, this makes it even more difficult for physicians to practice in these underserved areas. The result is individuals delaying care because they can't get an appointment or can't make the time to travel to another county for their medical needs. As a family physician, I can tell you that delayed care inevitably leads to worse outcomes, higher costs, and unhealthy patients. Nebraska needs to invest in healthcare. We need to keep rural hospitals alive. We need physicians practicing in large and small communities across the state. An increase in Medicaid rates will make a difference in the bottom line for physicians and hospital clinics and hospitals. It will increase access to care and help hospitals and physicians continue to provide the care that Nebraska needs. Thank you for your time. I'm happy to answer any questions.
Other questions from the committee? Senator Lippincott.
Obviously, we know we've got a shortage of workers here in the state. And can you tell me, with the personnel shortage in offices in the hospitals, how does that impact the services you can offer?
It's been very difficult. We've struggled to find staff across the board, front people answering phones, people receptionists, people doing billing, nursing personnel, ancillary personnel. Everybody is out there. We unfortunately have to compete with the hospitals and other systems for many of these same workers. Some people are just burned out. They just don't want to be in the healthcare arena because they can get paid the same, a pretty good wage at a fast food facility. And so we have to make sure that our wages, are very competitive, and then we have something else to offer these people. It's very difficult.
And also, you've been a volunteer's doctor of the day in the legislature several times.
A few times, yes.
It's a voluntary thing, doesn't
Yes,
pay
it is.
anything, and we appreciate your service that you offer. Thank you.
Any other questions? Seeing none. Thank you, Doctor, for your testimony. Are there other proponents for LB 128? Seeing none, is anyone here in opposition? Seeing none, anyone in the neutral capacity? Seeing none, Senator Dorn, you care to close?
Again, thank you for listening, and I'll just kind of waive closing. Probably there's been enough comments made that many of those people have made more than I can possibly do. So thank you.
Very good. Seeing no questions, we'll go to position statements. There's position comments on LB 128, 2 proponents, 2 opponents, and none in the neutral capacity. That concludes LB 128. We'll just add 1 and go to 129. We'll open the hearing for LB 129, Senator Dorn.
Thank you. Thank you again. Good afternoon, Chairman Clemens and
But
fellow.
just wait 1 minute. There's people coming and going here. Another minute. We need to get the door closed. All right. Senator Dorn, you're welcome to open.
Thank you. Thank you, Senator Clemens, Chairman Clemens, and fellow members of the Appropriation Committee. My name is Senator Myron Dorn, M-Y-R-O-N and D-O-R-N, representing District 30, which comprises all of Gage County and a portion of Lancaster County. I am here today to introduce LB 129 to state the intent regarding appropriations to the Department of Health and Human Services for Medicaid nursing facilities. LB 129 would appropriate funds for Medicaid nursing facility services under program number 348. The amount is not specified in the bill. However, in conversing with stakeholders, the total Medicaid amount requested for the biennium would be $40 million, which would reflect roughly $8 million in state general funds for each of the next 2 fiscal years. Those of you who serve on the Appropriations Committee previously may recall former Chairman Stener's intent with the nursing facilities appropriation. Last session, nursing facilities received a significant increase in appropriation for the purpose of offering competitive wages. Based on his analysis, Chairman Stener clarified that last year's funding was not sufficient to make nursing facilities viable over the long term. Chairman Stener's intention was to close this gap over a 3-year period with a plan to appropriate an additional $20 million towards Medicaid nursing facilities services each year. I have heard from members of my constituency that operate skilled nursing facilities about the tremendous increase in costs these facilities are facing. These costs, coupled with staffing shortages, unfunded federal mandates, and inflationary costs are crippling to facilities not only in my district, but across the state. You will hear from a few of these this afternoon. We have an opportunity this year due to the cost of living adjustments for Social Security recipients with which the state is able to utilize its Medicaid nursing facility savings to aid in funding this proposal. There will be testimony following my introduction to provide more information. And basically that part will be that each resident of a nursing home that their Social Security check goes towards the nursing home, they're allowed to keep so much of that. They will tell you about the dollars that they keep. I think Senator Holcroft has a bill out there this year to increase that rate, but because Social Security rate increase or the Social Security payment increase was approximately 9% in that neighborhood. Now that additional funding that went up, that level, unless Senator Holcroft's bill passed, that level will stay the same amount for the residents. So that other amount, instead of going to the state, that's the proposal in this here that would now go to the nursing facilities. So there will be more people later that will be able to clarify and talk more about that part of it.
Questions? Seeing none, thank you. We'll welcome the first proponent for LB 129. Good afternoon.
Good afternoon, Chairman Clemens and members of the Appropriations Committee. My name is Jalen Carpenter, Jalennecarpenter. I'm the president and CEO of Nebraska Healthcare Association. On behalf of our 184 nonprofit and proprietary skilled nursing facility members, I'm here today to testify in support of LB 129. I thought it best to start simple and define a nursing facility. They're commonly referred to as skilled nursing facilities or nursing homes. Nursing home care is provided by licensed nurses and nurse aides under the supervision of a registered nurse. Nursing homes care for those who typically have complex medical conditions, multiple chronic illnesses, and those who need assistance in performing their own basic care. These are individuals who cannot usually be cared for safely in their own home. For a Nebraskan to qualify for Medicaid to pay for their nursing home care, an individual must meet the financial criteria, essentially being low income and having no more than $4,000 in assets. And then the individual must be determined to meet medically necessary requirement. It is critical to understand that nursing home residents who receive Medicaid benefits are hardworking Nebraskans who supported their families and contributed to their communities. They truly believe they planned responsibly for their future. They simply outlived their resources. According to the department, in January of 2023, 60% of the nearly 10,000 Nebraskans in nursing homes relied on Medicaid to pay for their care. Simply put, for every 10 nursing home residents, 6 depend on Medicaid. Because nursing homes serve a highly vulnerable population, they are heavily regulated by the federal government. The COVID-19 pandemic brought an onslaught of unfunded mandates and overly burdensome restrictions that did and continue to require additional staff. For a state with historically low unemployment and an underfunded industry that was already experiencing staffing challenges, these restrictions only exacerbated the problem. The result? Nursing home closures. The last 11 closures have been all in rural communities. Many facilities are now turning away residents, and families are driving great distances to find available beds for their loved ones. You have in your handout a map of the care desert that now exists in Nebraska. As a solution-focused association, we identified a way to fund LB 129. We believe there's a Medicaid savings as a result of the Social Security cost of living increase that requires nursing facility residents to pay a larger portion of their nursing facility payment, and that Medicaid or the state to pay less. An example of this is on page 3 of my handout. We have been in conversations with the department since December of 2022 regarding this cost of living increase, and we appreciate the collaboration. And although they have told us that this increase would be included in the nursing facility rate, we are still unclear how the calculation is made. Therefore, we believe in order for the savings to be included in nursing facility rates, there needs to be an appropriation for additional dollars. I would like to thank Senator Dorn for his introduction of 129, and I would be happy to answer any questions.
Other questions? Seeing Senator Erdman.
Thank you, Senator Clemens. Thank you for your testimony. Didn't the Appropriations Committee appropriate extra money last year for nursing home?
Yes, they did.
Did they spend all that?
There was two. So are you talking about the ARPA funding or the Medicaid rate increase?
All of it.
All of it. Yes. So the ARPA funding was distributed by the states to the facilities that they have reported in their cost report. It was very specific. It was only allowed to be used for recruitment and retention of staff. So it went solely towards those incentives. As far as if you're asking me if the amount of the provider rate increase covered their cost of care, no, it does not continue to cover the cost of the care that is required for a nursing home resident.
So you're saying they used all the funds that we appropriated?
Correct.
Other questions? Looking at your sheet here, you're showing a $159 difference in the payment that could be a savings time. That's times 6,000 potential residents.
Correct.
That's $954,000.
So when we did the analysis, maybe I didn't look correctly, based upon conversations we've had with the department and with a third-party consultant, they estimated it to be roughly $10 million. Again, what we gave you was an average, and that would be per month. And then if you take it over the course of 12 months. Yep.
Times 12.
Yep. There we go.
It's 11,400,000.
And that would be state and federal funds.
That's not just state funds.
Correct. That would not just be general funds. The savings would be the cumulative.
That's the combination of state and federal.
Yes.
All right. Other questions? Senator Lippincott?
What type of attrition rate do you have?
When you're talking about, are you talking about for residents, the length of stay, or
Nurses.
for nurses? And there's operators behind me that can speak directly to that. I can get you with total turnover ratios. I don't have that. I can tell you in the handout on the second page, it talks about, on the first page there, it has our percent of openings that we still have based on the Bureau of Labor Statistics. That would be all staff. I think it is important to understand that nursing facilities, a large portion is RNs and LPNs, but the greatest portion of their workforce is CNAs. CNAs, housekeeping, dietary, that is the largest portion of their workforce.
Corporate changes next year by December to January. It's 1826 and then it's 1985. Is that a difference between how much the Social Security payments went up?
Correct.
Okay, so it's about $170.
Yeah, roughly. I think Senator Clemens might have done the exact math.
159.
Okay, oh, 150, that's it? Okay, I understand what your question was. Thank you.
Yep.
And let's see. Other questions? I would ask about Senator Holdcroft's proposal been mentioned. Does this take into account that adjustment?
It does not, and I believe Senator Holdcroft's bill would have an appropriation amount to it of what that would cost the state.
And does your association support that bill or not?
Yes, we sent a letter.
You are. Okay. Do you know the bill number?
I apologize.
We
I
can
don't.
find it. All right. Right. All right. Very good. Thank you for your testimony.
Thank you.
Next proponent. Welcome.
Thank you. Hello. Hi, my name is Shay Indra, Chayindra. I am the secretary of a 5-person volunteer nursing home board in Clarkson. I have been on the board for 12 years. I have been involved with the facility for over 20. I've been an employee, a family member to grandparents that were residents, and an outpatient receiving therapy after surgery. Clarkson Community Care Center is rated a 5-star facility on CMS's Nursing Home Compare. Nursing Home Compare ranks all nursing homes as well as other healthcare agencies on a scale of 1 to 5 stars, 5 stars being the best. It is based off of survey results, staffing metrics, and quality measures. Our community depends on us to provide respite care, short-term rehab, long-term care, and therapy services. Prior to COVID, we had also had community members that would come in for baths, blood pressure monitoring, and just general nursing questions. We also provided Meals on Wheels. Clarkson is a town of a little over 650 people, and it has a strong Clarkson Czech heritage. Many residents of the facility were business owners, farmers, teachers, and clergy in the community. The grade school kids have field trips to the nursing home to play bingo or to do crafts. The high school kids walk through on prom to show off their dresses or to drive through the parking lot in their tractors during FFA week. There are many high school kids that get their first peek at the healthcare profession by working as CNAs and as dietary aides. I would like to share some of our metrics with you. We employ about 50 team members and serve 36 residents. Financially, I am not sure what the future holds for us in the next 1 to 3 years. We are having a loss every month. It is simply that it costs more to care for the residents than what we are being reimbursed. Currently, 50% of our residents utilize Medicaid to cover their stay. Financials from July 1 to December 31 show a loss of $94,174 for those 6 months. Our average expense is $267 per day per resident, with the average revenue being $257 per day per resident. This means that we have a loss of $10 per resident per day. We do have staffing challenges. We utilize the agency nursing. Our administrator covers many different roles within the facility, from cooking to laundry to managing the supply and stock room. Our dietary manager not only cooks meals, but also does transportation to get residents to their appointments. As I think about my time in front of you, I think it's very valuable to tell you a story about one of the elders that we serve. This is about a couple that I know very well. He recently moved into the nursing home. He and his wife have been married for more than 60 years. He was a business owner in town, born and raised in our area. He is very well known and gets many visitors to help pass his day. Because of his illness, he cannot communicate well, but he does understand. People visit him to tell him about what's going on with the farmers, what's happening in church, and all the preparations for our check days. His wife goes to see him every morning and every evening. While it's not home, he is adjusting well. If the facility were not to be here anymore, she would not be able to see him every day. I'm not sure she'd even be able to see him every week. It would be a lot harder for his friends to stop by and visit. His quality of life would decrease significantly if the people that he worked with and served in the community were not able to visit and tell him about all the things that he loves and values. I've been around healthcare my entire adult life. The facility does amazing things. We employ passionate people and we care for our elders in our community. We want to continue to be able to do this for years to come. I get it. You have a really hard job. Everyone's asking for funding, but as you go back and start making decisions, I just ask that you think about all of the nursing homes in Nebraska, all of the Clarksons of Nebraska. It's a very tough decision, but we're worth it, and the elders of Nebraska are worth it. Thank you for your time. I'd be happy to answer any questions.
Other questions? Seeing none, thank you for your testimony.
Thank you.
Next proponent. Welcome.
Hi. My name is Bob Tank, B-O-B-T-A-N-K. And thank you, Senator Clemens and the Appropriations Committee I'm a proponent of the LB 129. Like I said, my name is Bob Tank and I have been administrator at Bethany Home for 15 years. And I've been a long-term care administrator for 26 years, and I've worked in long-term care for 42. We had our accountants do a cost analysis between fiscal year 2017, 2018, and fiscal year 2021 to 2022, and our expenses, our costs, went up 41% in that time frame. So that was a difference of $90 per day. And so if we, each one of them years, the first year, our cost went up 7.15%, and most of that cost was due to raises of staff. The next year, our costs went up 1.66%. And we did no increases that year. We did a 25-cent across the board increase. And so for 2019, 2020, from 2020 to 2021 fiscal year, our cost increased 9.32%. And that was due to increases staffing agency. And my assumption is we didn't do rate increases enough or didn't do wage increases enough the year before. So we lost several staff and because of COVID. And so the next year, from 2020 to 2021 fiscal year to 2021 to 2022 fiscal year, our costs went up 18.11%. And that was due to we increased wages and we increased an increase in staffing agency. We did an increased wage scale February of 2022 and July of 2022. And the difference between July of 2021 and July of 2022 was a 21.48% increase in wages that we did in 1 year. So that was about $1.18%, or $1.18 an hour and that was for non-managerial employees. which did assist us in recruiting new employees. Our facility had gone from all agency and housekeeping to no agency and housekeeping. And agency utilization in nursing has decreased in the last 3 months from 180,000 to a month to about 65,000, March 2023. Thank you for your time, senators. Is there any questions?
Other questions? Where are you located?
Minden.
Just the one location?
Yep.
Is that it? All right. Thank you for your testimony. Next proponent.
Good afternoon. How are you guys? I'm a little nervous, just to let you know. I'm from western Nebraska, out in the middle of Scottsbluff and Alliance, a little community called Hemingford, Nebraska. About 800 people total. They've all done such a wonderful job talking about finances and where we sit.
Could you give us your name?
Oh,
and
I'm
spelling?
sorry. Yes. My name's Lori Danner, Loridannar. I'm from Hemingford, Nebraska. I serve the Hemingford Community Care Center. So Hemingford, 35 years ago, sent people down here on 3 bus trips to get the certificate of need to even build our center. Alliance is 20 miles away. They had 2, and Hemingford did not need one. But we felt like 20 miles was too far for a family to drive. And my mom rode down on those buses 30 years ago. It has been in our family ever since. My mom has since passed in that nursing home. My dad has passed in that nursing home. 20 miles for me to drive to Alliance to see my mom and dad every day doesn't sound like far. I come to Lincoln, Nebraska, and I have all the we don't even have one stoplight in our town. So I get nervous when I'm coming down here, but that's how we live. We are rural Nebraska. We have farmers and ranchers that have put every dime back into their farm and their family to live and to think about. My mom bought long-term care insurance, thank God, but there's very little education on it. I think a big plus for future would be education on this, because most people that I talk to, well, Medicare will pay for that. I have Medicare. I have Medicare and a supplement. Education needs to be a prime thing looking forward into the future. But that's future, and we're here today. We have 36-bed nursing home, 13-bed assisted living. I just worked really hard on a lady that lives 60 miles away. She was in Colorado at the hospital. We helped her get onto Medicaid so that she could come to our facility 60 miles away from her family because she's on dialysis. Her family did not know we even existed. And now they can't believe the compassion that our staff has. Through COVID, we had contracted labor. We had agency. We were paying one RN $80 per hour, and my DON makes $35 per hour. We financially couldn't sustain as a independent facility anymore, so we have since went with a leasing company, which I have support here today from Jeremy. He's with the Vitas Foundation. They are helping us find our way to remain sustainable, because Medicaid dollars are not supporting us enough to keep our loved ones close to home. And that's what every facility is built on. Each one of you are going to have a parent, a grandparent, a wife, or a husband that someday will need a nursing home. And stop and think, if you have to drive 60 miles to hold their hand while they're dying, and you have to be away from your other family, your job, how hard is that going to be? So look into the future. Today we have an opportunity to help within the next couple of years, but this is going to be an ongoing problem because we are just getting more and more with the elderly. There's more of us. I'm going to be one here before too long. And I want the staff that I have at my facility. My staff, we have not given my staff a raise in 3 years because they choose to care for the families, the residents that are there, but they're getting burnt out. And you guys have the opportunity to help. Not only the staff, the facilities, and our communities, but if my facility closes, my community could close because they also get supported from my facility to stay open. So my community of 800 may not exist in 5 years down the road if my facility isn't. Thank you.
Other questions? Senator Erdman.
Thank you, Senator Clemens. Thank you for coming. I would assume you came yesterday
Yeah,
and you probably won't go home until tomorrow.
right,
So it took you 3 days to come and testify for 5 minutes.
correct. And
I
I am very
appreciate that.
honored, let me tell you.
I appreciate that. So you have 36 beds.
Yes.
How many residents do you have?
We right now have 19 residents.
Okay, so why don't you have more residents? You have not enough help to do that, or what's the situation?
Help is one reason. We were low on staff. With VITAS Foundation's help, we just became Medicare certified. We were only, I won't say only because it's a very important part, but we were a nursing home. We were not skilled, so we couldn't accept Medicare patients. We now are as of February 1st, so that's going to help us because 90% of those that need help come from the hospital. They need rehab or they need a skilled care, maybe short-term, maybe long-term, but where we didn't have that component. So we're just now getting into the Medicare aspect of it and a large learning curve there too. But it's exciting. You guys are doing an awesome job, and healthcare is exciting. Helping elderly that next transition into the next life, death. Not very few come into a long-term care facility that are going to leave, and we're the last people that they see. And to be able to be caring, kind, and know that you all understand what we go through every day and are willing to put that money out there to help us is a godsend. So thank you.
Senator Erdman. Thank you, Senator Clemens. Is there a list of people, you have options, people waiting to get in?
We've had 4 referrals that we are looking at, but 3 of them are, as they said before, it's a 56-year-old that's a meth and cocaine, and to put them into long-term care with an 80-year-old farmer might not be conducive. And so there are some issues that we just can't help some. Being in a small community, Crawford, Chadron, Alliance, we all have long-term care, so we're all vying for the same people from a few hospitals. And home health has helped keep people home a lot longer, so they're not coming to the nursing home as soon. COVID scared a lot of people. I don't want to be locked up. If I go to a nursing home, our regulations are, you get COVID, they have to stay in their room. Do you guys want to stay in your room and not come out for 14 days? We bring you your meals. And still today, that's what's happening. We have to hold them in their room per ICAP for 14 days to ensure that we don't. So why would you want to come to a long-term care facility? So they are looking at that whole aspect a little bit closer as far as, can I keep mom and dad home just a little bit longer before maybe COVID's going to go away May 11th. Maybe magically we won't have to do that anymore. So those are some of the issues.
So how many employees do you have?
We have 43 employees.
So I would say next to the school, you're probably employing more people than anybody else in town.
School and our co-op Wesco, we have a grain elevator there that employs. But yeah, we are the next largest.
Are you familiar how Crawford's getting along?
They're still struggling. They had looked at closing. In fact, they had VITAS also go there and visit with them. I just visited with someone from there. They are hopefully on a better track, but they are struggling also.
Did they not sign an agreement with the company to manage that?
No,
They didn't?
no, they did not. They stayed, I think rural health is still helping them, rural health development. Cynics of Nebraska has been or VITAS Foundation has been a godsend to help us get going. We are also applying for the Veterans Administration for Box Butte County. So hopefully that will help too, because our veterans deserve awesome care.
How long have you been working with Senex?
In May will be 1 year.
Good.
Yeah,
They're in Bridgeport as well.
yes, yep,
Outstanding.
yeah.
Doing a
So
good job. Thank you.
you're
Thank you for
welcome.
coming.
Thank you, guys.
Senator Dover.
I'm not familiar with who Vetus is.
VITAS Foundation, their main offices are in Colorado and Florida. They will either come in with a management contract, or we chose, we were village owned. The village chose to sign a 10-year lease agreement. So the building and property are still the village's, but the business aspect, VITAS has now. And so they're in charge of finances, taking care of all of that, the billing problems and all of that good stuff. We just get to focus on residents. So they're hopefully taking over, or not taking over, but they're going to be assisting other facilities too. They have a lot of knowledge, a lot of fortitude. If you get the facilities working together as a team, I think it helps. We're all in the same business. We're not here, I'm not trying to steal residents from Alliance. I'm trying to, let's work together, because they may have a knowledge that I don't have, and that's what VITAS brings to the table, because they're helping other facilities so we can share ideas.
Is VITAS a nonprofit foundation?
For profit.
Okay.
Yes.
Thank you. And do you know what your Medicaid resident percentage is?
We are approximately 85%.
85%?
Yep. Because we are a rural farming area. My mom and dad qualified for Medicaid when we were growing up, but didn't take it because they were proud. They were going to do it. And a lot of families just don't have the
And
funds
with
to put away.
Well, and then with Medicare eligibility, you may lower that percentage, I would hope.
Yes, hopefully soon in the future.
Did you have to hire more staff to become Medicare skilled?
Yes, and that's a problem because we don't have very many RNs in our little area. The RNs that are there, of course, our RNs were paying $32 to $37 per hour, and then go to the hospital 20 miles away and make more. Or another facility that's been Medicare longer and can afford to pay more. But it's our smiling personality that keeps them there.
All right, well, thank you for your testimony.
Thank you very much.
Next proponent. By the way, good job. You didn't seem too nervous. Welcome.
Hello, welcome. Good afternoon, Chairman Clements and members of the committee. My name is Michelle Pleger, MICHELLEPLOEGER, and I'm testifying on behalf of Quality Living, Inc., a specialized nursing facility in Omaha. Many of you are familiar with QLI and the one-of-a-kind rehabilitation and residential care services we provide to individuals who have suffered a brain or spinal cord injury. QLI's care continuum includes a licensed, specialized extended rehab nursing facility whose reimbursement rate is determined in part by the application of the inflation factor. Though not the classification of nursing facility that will be more widely impacted by this bill, we too have a stake in its outcome because our Medicaid reimbursement is allocated from the same source. QLI has not historically taken a position to advocate for rate increases. Rather, our focus has been on providing incredible care as effectively and cost efficiently as possible, even volunteering rate cuts at times. For over 30 years, we've been able to produce outstanding outcomes for individuals, families, and the state of Nebraska while saving Nebraska millions of dollars. Since the inception of managed Medicaid, however, we have been forced to change our stance on advocacy due to the financial impact of managed care. QLI's short-term rehab nursing facility has fallen under the purview of managed care, Heritage Health, since the most recent expansion. Our experience with managed care is that the MCOs focus on short-term cost management at the expense of the best long-term outcome for members and the state. This impacts QLI especially because we serve members with complex, lifelong medical needs. Despite our patients' high needs, the MCOs have cut off funding for continued inpatient stays in shorter and shorter timeframes. This has left QLI in an ever more frequent position of providing necessary care to achieve a safe and successful transition without getting paid for it. Since 2017, the total cost to QLI for these unfunded services is nearly $1 million. QLI also incurred costs during this time for the increased overhead in appealing inappropriate denials, including approximately $100,000 in attorney fees since 2020. We've been able to absorb this degree of revenue loss due to sound management and a healthy payer mix, but the impact is great and it's not sustainable. Because the MCOs apply utilization management and reimbursement practices similar to commercial insurance, which is inefficient at best, QLI has also had to increase spending on payroll by adding more staff to our team to meet reporting and claims processing requirements. Within the past 5 years, we've added 8 full-time staff to meet these demands, resulting in approximately $650,000 in increased spending annually. Given that managed Medicaid is not going away and the likelihood of expansion to long-term care, we foresee significant financial struggles for nursing facilities faced with the same challenges we have experienced, on top of the financial strains that others who have testified about today are experiencing. The rate enhancement proposed in LB 129 would provide much needed support to QLI and every other nursing facility who accepts Nebraska Medicaid now and into the future. Thank you, and I'd be happy to answer any questions.
Other questions? Seeing none, thank you for your testimony. Are there additional proponents for LB 129? Seeing none, is anyone here in opposition? Seeing none, is anyone in the neutral capacity? Seeing none, Senator Dorn, you may close.
I want to thank you again for allowing us to introduce that bill, and thank you for some of the testifiers and stuff. So I haven't been doing that in the past. For some people to come from Hemingford down here takes a commitment. Just ask Senator Erdman how often he drives that stuff. So with that, I'll take questions. Otherwise, I'll waive my closing again. I think there were some real good comments.
Any questions? Seeing none, thank you. And we have position comments for the record on LB 129, 20 proponents, no opponents, none in the neutral capacity. And that concludes the hearing for LB 129. In just a minute as we rearrange the room.
Thank you.
We're fine.
All right, now we're ready for LB 130, Senator Dorn.
Good afternoon, Chairman Clemens and also members of the Appropriations Committee. My name is Senator Myron Dorn, M-Y-R-O-N-D-O-R-N, representing District 30, here to introduce LB 130. LB 130 is introduced was similar to LB 340 brought by former Chairman Stinner in 2021 to create a separate Medicaid nursing facility budget program. This bill was given a committee priority. However, time ran out in that session, and with the end of the legislative session, the bill was indefinitely postponed. I'm here to bring it back into the spotlight with proposed amendment in an effort to capture current practice in statute and eliminate the need to repeatedly add this language to each biennial state budget. We understand the department's opposition to the previous bill and concerns about the original draft of this bill is that it would create a new and separate budgetary program. AM 899 will eliminate that barrier. The amendment will become the bill and will be put into statute. The language this committee has included in the budget for the past 3 years. This bill as amendment specifies that the total amount appropriated to the department for Medicaid nursing facility services be utilized in the calculation of rates and used as the base for funding for the following fiscal year. AM 899 would also require the department to continue to file its 2 annual reports with the Legislative Fiscal Office and Clerk of the Legislature. The bill does not appropriate funds or require that funds be appropriated. Identifying funding would continue to be the responsibility of our committee through our usual budget process. Bill, and I think we've had time or two, we've talked about it. I think, I know Keisha was there when we talked about it. We put this intent language in the budget every year. All this is doing is if we put it in as a statute, it however has to come to the floor and be passed, which I think everybody knows what's going on this year and if it might sit there again. But we did have a conversation with the people from DHHS last week or the week before. We've had several visits with them since then. And out of that has come the white copy or the white amendment, which is going to be the bill. So other than that, I would take any questions.
Are there any questions? Okay. So the amendment changes just some wording so that they're more comfortable with how the process works?
Yes, yes. We did have a visit with them. We've had several visits with them. Some other people on my staff and me, I did have with the first time. We've since talked to them again. They're going to be here to testify probably in opposition to the green part, but in neutral to the white part, because it is something that they wanted to have some input as we brought that forward so that when that could maybe become a statute, that it, they were involved in the process.
Very good. All right, well, let's invite proponents for LB 130. Welcome.
Welcome. Good afternoon, Chairman Clements and members of the Appropriations Committee. My name is Cindy Cadavy, CINDY, KADAVY, and I represent the Nebraska Healthcare Association. On behalf of our 184 nonprofit and proprietary skilled nursing facility members, I am here today to testify in support of LB 130 as amended by AM 899. So some of you may recall that former Senator Stinner introduced a similar bill. Senator Dorn mentioned that as well. And what that did, his effort was really to continue the transparency and the accountability that this committee worked really hard to develop around the nursing facility rate calculation process. So 5 years ago, any increase in the nursing facility appropriation was indicated as a percentage in the budget, and that inadvertently caused a misunderstanding in the calculation of the nursing facility rates, as the department was starting with a different number than the legislature intended. So to remedy this situation in collaboration with our association, the department, and the fiscal office, the committee added language to the state budget to earmark a specific dollar appropriation for nursing facility services, required the full appropriated amount to be used in the rate calculation, and require an annual reporting of how the rates were calculated and any unspent funds back to the legislature. And these were small changes, but they made a significant difference in the nursing facility rates and in building trust between providers and the department. So as Senator Dorn referenced, initially LB 130 would create a separate budgetary program, but that was the concern of the department. So when we met with Senator Dorn's meeting, which he hosted with us in the department, we talked about possible alternatives. So based on that discussion, we feel like AM 899 does address the department's concerns. So as amended, the bill would simply place the budget language in statute. So it would no longer create a separate budget program. It would just take that language out of the budget and put it in statute. The department's already providing those 2 annual reports, so it would not add any additional reporting. The department has also consistently told us they appreciate the appropriation being identified as a dollar amount in the budget and the guidance on how the legislature wants the rates calculated, because that means the legislative intent is clear to everyone. The bill as amended by AM 899 would simply codify the current practice. We'd like to thank Senator Dorn for his introduction of this bill, and happy to answer any questions.
Any questions? Seeing none, thank you for your testimony. Additional proponents? Are there opponents? Good afternoon.
Good afternoon. Good afternoon, Chairman Clements and members of the Appropriations Committee. My name is Jeremy Brownson, Jeremy Brunssen, and I am the Deputy Director for Finance and Program Integrity in the Division of Medicaid and Long-Term Care within the department, the Nebraska Department of Health and Human Services. I am here on behalf of the department to testify on LB 130. The department opposes LB 130 as originally introduced, which would create a separate DHHS budget program for Medicaid nursing facility services. The department's position is neutral with respect to the draft AM 899 language shared with us. LB 130 as originally introduced would significantly alter the way we do business, add a number of complexities, and add administrative costs without bringing forward any known direct positive impacts for providers or beneficiaries. Separating these funds would limit Medicaid's ability to manage a budget should there be changes or increases in utilization that could create situations where we would need to request deficit funding in order to continue to pay nursing facility claims. We've been able to manage these within our budget in the past without needing to take such action. The department generally does not support the concept of codifying business processes or methodologies in statute, but does acknowledge that the language in AM 899 reflects the language that is and has been in recent budget bills. Therefore, we do not anticipate any operational impacts to the department with the language we've had the opportunity to review. The department values the ongoing working relationship that we enjoy with the long-term care provider community and associations. We've greatly appreciated the opportunity to meet with Senator Dorn and the Nebraska Healthcare Association to share our concerns with the original language in LB 130 and the thoughtfulness that has gone into the proposed amendment to mitigate our concerns. Thank you for the opportunity to testify, and I'd be happy to answer any questions.
Other questions? Senator Erdman.
Thank you, Senator Clements. Thank you for being here. Were you familiar with what Senator Stenner tried to do last year?
I would say yes, sir. Thank you for the question, Senator. I've been very involved in the nursing facility budget. I've been a part of many of the conversations with Healthcare Association and with the legislature in the past.
So was it true that Senator Clements or Senator Stenner was worried or concerned that all the money that was appropriated wasn't actually spent? Wasn't that his concern?
So I would say there's a lot of history. I don't know that was a concern last year. I can say when I joined the department in 2017 or the fall of 2016, some of the very first meetings that we had were with the Healthcare Association and really just trying to drive out transparency in the process. Being new, I was able to come in and take a fresh perspective. And what I evaluated was, There was just I would say there was friction and misunderstanding between the department, the association, and providers because, we were in a position where we're using prior year information to develop, prospective rates and try to estimate what utilization was going to be in a future period. So the department had a process that had been being used for years. It wasn't changed. But I think that the way that the budget was intended to be built, didn't reflect that process. It reflected kind of a different understanding going in. I can't speak to what it was specifically. So I think there was a disconnect initially that, hasn't existed for the last few years.
So what was your opposition to the green copy?
So our opposition is really creating a separate budget program doesn't actually solve any problem that exists today. We do not, pay out of budget programs based on a facility type or type of service. It's based on the member's eligibility. So we would have to go in and recode our MMIS. It creates a level of complexity. Nursing facilities not only bill for just the normal standard nursing facility payments, but they also have hospice and therapies that they bill. So it creates a lot of complexity and I think would probably cause some errors and really doesn't bring a lot of value. It's not going to increase what we're paying.
So then if you're neutral on the amendment, is that correct?
Correct.
So then you shouldn't be concerned at all if we pass this bill.
We came in a position as a bill, our opposition was truly to the introduced copy of 130, the original copy.
But the original copy 130 is no longer here. It's AM.
Well, I don't believe it's actually the amendment's been introduced yet.
So we've sat here for several days and listened to people having issues with the way the department does the appropriations and distributes funds. And I can see why these people are concerned about having it in the statute. It's been difficult listening to some of these people's testimonies. So I think that the amendment looks good to me.
Are there other questions? I think we have been unclear as to why it's so hard to just account for something separately so that we can see it split apart. And you're talking about with Medicaid, would you refresh us again on why it is hard to separate that?
So there are a lot of considerations that go into why the department would be in opposition to a separate budget program. One example would be, while the intent is for, very, clear transparency around exactly how much of the money that the department, spent of the appropriation, I understand the intent, but there are consequences tied to that. In a given year, if we have utilization, if we have more members in the nursing facility that receive services than what, anyone projected, which has happened, we would actually run out of money in the budget program, where today we can continue to pay because in the Medicaid broad budget, utilization shifts occur. Maybe one year we have more people getting hospital services, the next year more nursing facility. It allows us to manage the budget without, in the scenario where it's in its own budget, our claims would fail. We couldn't actually process payments unless we had a deficit approved for that specific budget program.
I see. So if it was a separate program, you would be limited to those dollars, where all combined, you can shift from one type of service to another.
Right, correct.
Well, that is helpful. Any other questions? Thank you for your testimony. Are there other opponents? Seeing none, is there anyone here in the neutral capacity? Evidently not. So Senator Dorn, do you care to close?
Thank you. Thank you for having that conversation. I just wanted to reiterate that we did visit with them a couple weeks ago, and we've had several visits since then, and they knew before they came in here that we were going to replace the green copy with the white copy. That was part of what the conversation had been, and we'll continue to have that as we go forward with our budget. Thank you.
All right. Thank you. Regarding LB 130, we have position comments. 4 proponents, no opponents, none in the neutral. That concludes LB 130. We will now open the hearing for LB 131, Senator Dorn.
And I believe this is my last one today, I think.
It is.
Yes. Thank you. Thank you for listening to all of them. And I appreciate sometimes how the schedule is put out so that we kind of have a theme day or whatever. I'm very thankful for that. And also, as you visit with many of the people that sometimes are here for the different bills, that they're able to come in 1 or 2 days, especially if they're from farther away. Good afternoon, Chairman Clemens and fellow members of the Appropriations Committee. My name is Senator Myron Dorn, M-Y-R-O-N and D-O-R-N, representing District 30, here to introduce LB 131. LB 131 would appropriate funds for Medicaid waiver, assisted living facility services under Program 348. The amount is not specified in the bill. However, in conversing with stakeholders, the total Medicaid amount requested is the amount necessary to increase rates to the amount determined by the department's contractor. We roughly estimate this amount for the biennium to be approximately $13.5 million, which would reflect roughly $4.9 million in state general funds for state fiscal year 23-24 and roughly $1 million for 24-25. We will work with the department to get these exact numbers. Those of you who served on the Appropriations Committee last session may recall that former Chairman Stinner introduced LB 988 to appropriate funds to the department to carry out a former Medicaid waiver assisted living rate study. The bill was advanced to general file, but time ran out on the session and LB 988 was not taken up for debate. In the meantime, the department opted to contract with a third party to carry out their own rate study of Medicaid waiver services by conducting a detailed cost analysis and rate comparison with other states. LB 131 would appropriate the funding necessary to increase the Medicaid waiver assisted living rates to the recommended level in the study's preliminary report, which identified a significant gap between the current payment for those services and the actual cost of care. Based on speaking with assisted living providers in my district and other parts of the state, it is important that Nebraskans, especially those who are on Medicaid, are able to seek assistance but don't require 24-hour nursing care. Those speaking after me will be able to provide additional information on the study and how an increase in rates would increase access to assisted living for Nebraskans reliant on Medicaid to pay for their care.
Oh, that's it. Other questions? Senator Erdman?
There is. Thank you, Senator Clemens.
Dorn.
Senator Dorn, interesting, at the bottom of that statement, it says the department contract with a third party to carry out their own study for Medicaid waiver. Can you find out how much that cost?
I don't know, maybe some of the ones speaking after me. If not, we will try to gather that information. That would be interesting to know. So, especially since we had a bill asking for.
Thank you so much.
A study. Thank you.
Other questions? Seeing none. Proponents, welcome.
Good afternoon, Chairman Clements and members of the Appropriations Committee. My name is Jaylene Carpenter, J-A-L-E-N-E-C-A-R-P-E-N-T-E-R, and I am the President and CEO of Nebraska Healthcare Association. I am speaking on behalf of our 232 nonprofit and proprietary assisted living community members, and we are here today to testify in support of LB 131. I want to clarify, we are talking about assisted living, so I'm going to again start kind of simply. In Nebraska, an assisted living facility is a residential setting where shelter, food, and personal care assistance with services such as social activities, housekeeping, laundry, medication assistance, and transportation services are provided. Assisted living facilities are regulated at the state level. An assisted living facility is not a nursing home and cannot provide ongoing care by licensed nurses. Nebraska seniors in an assisted living facility may qualify for services that fall under Nebraska Medicaid Waiver Program, which was established in the late 1990s. It is our understanding that there had never been a formal rate study of the assisted living rate prior to the one conducted last year. Since the establishment of the program, the provider rate increases received have not kept up with the cost of care. In 2022, the Department of Health and Human Services contracted with Optimus and Myers and Stauffer to conduct a rate study of services provided under the Medicaid waiver program. The goal of the study was to analyze the cost of providing care and determine reasonable Medicaid rates. Although the formal report has yet to be released, in October of 2022, a preliminary recommendation was issued. I have provided you with a copy of the Optimus Assisted Living Facility rate recommendations. They recommended parity for urban and rural rates because there was no cost difference. LB 131 requests the legislature appropriate the funding necessary to implement the department's recommended rate of $83.84 per day as identified in the study. I have to clarify, it wasn't the department's recommendation, it was their third party's study that recommended the rate. I urge the committee to include LB 131 within the mainline budget to assist communities across Nebraska in the continued care of our aging demographic. There are testifiers after me that will speak directly to their individual operations. I would like to thank Senator Dorn for his introduction of LB 131. I would be happy to answer any questions. I do not know how much the rate study cost.
Thank you.
Other questions? Do you know what the current rate is per day?
I do. Man, maybe I do. I will get that information for you.
All right,
Sorry.
that's all right. All right, thank you for your testimony. Are there additional proponents?
Thank you, Senator Dorn and Senator Clements and Appropriations Committee for listening to our testimony. My name is Mar Fritz. I'm from MARV, FRITZ from O'Neill, Nebraska. My wife Dee and I own and operate a small standalone assisted living in O'Neill. You have a more detailed version of my testimony in your packet. I'll try to highlight our positions. I'll use the acronym AL for assisted living and SNF for skilled nursing facility. I'll try to show you why this bill could potentially, I think, be revenue neutral. Failure of this bill has the potential to end Medicaid waiver for assisted living in Nebraska, most of Nebraska. We're currently subsidizing the state about $1,385 per waiver resident per month in our facility today. Last year, you gave us $20 a day to help with labor costs, and it was a one-time, and it covered about half of the deficit from the cost study. Labor accounts for about 66% of our costs, and we cannot compete in the hiring market when we're getting so much less than you provide the SNFs and other health services for the nursing and the care staff that we need. I'm sure they needed the money, but I don't know why he left AL completely out of the mix. Even at the requested rate, we are still going to be underfunded because those study numbers are already 2 years out of date and the highest inflation we've had in 40 years. We saw a DHHS program on Monday about reporting requirements, not supposed to be required now, but it will happen. We're already keeping all the records they're requesting, but would have to have a different format just for waiver. If you pay us for this, we can accommodate it, but you probably won't. The extra record keeping was not included in the cost numbers. AL was conceived as a social model, and it works very well as that. Every effort you make to move it into a medical model is destroying it, quite frankly. The bottom line is more reporting is not going to improve the care. It's just going to improve the cost. We believe this bill could end up saving the state money, and this is why. If the rates were more fair, we believe that a lot more assisted living facilities would take waiver residents versus they have to go to nursing homes now because they can't stay in no. Assisted living won't take them because the rates are so low. Half of the assisted living in the state are tied to a SNF, so they can move them over in their own facility. The other half don't take any at all, or the other half that are left. And that leaves us small people out there that are in a rural area and only have one facility, having to take care of both people at the same levels. It costs the state on average about $100 a day more more to do in a SNF than it does in an AL for the same care. And about 15 or 20% of the lower end of those residents could be put in an assisted living if they would accept them. And that would essentially be enough money, save the state enough money to pay for the other $40 a day that we need to keep our end of it going. The alternative is going to be pretty soon. We'll have to send most of those 1,700 people into a SNF, and that's going to cost you about $50 million a year. So, we're in that group of small ALs. We don't want to force people to move when they run out of money. It's a huge physical and mental handicap to the residents. And we believe that we can successfully care for these people for the remaining days. We've introduced physical therapy and a few other things into our facility, speech and occupational. I know it sounds morbid, but we keep a lot of our people to within 30 or 45 days of end of life now. If we can do this in a social setting, and we think we can, it will cost the state much less overall. And our last point was, as Jaylene had mentioned, that the rural costs in the study were shown to be as higher than urban, and we would sure like to at least fix that. We can't continue to subsidize the state much longer, even without the new reporting requirements. So if you ask us to do more for the same money, our decision is going to have to be pretty easy. They're just going to have to go to skilled facilities. For $50 million a year, you can get all the reporting you want. We'll move on to something else. We don't want to, but we'll just have to. And it will hurt us. There's no doubt it will hurt us, but it will be doing a lot more disservice to your constituents. And I think if you do this correctly, I think it could be close to revenue neutral. It's an opportunity to make a good thing better, and just instead of being more expensive. Thank you for your time, and I'll take any questions.
Questions, Senator Erdman?
Thank you, Senator Clemens. Thank you for coming all the way. So how many available beds do you have? How many people will you house at your facility?
We have 53 units, currently have 45 residents in AL.
So how many people do you employ?
30. I write 33 checks in a month. We have 20 full-time, and the balance are part-time, evening, dinner help, that sort of thing.
And most of your residents are local people? Most of your local residents are local people?
Pretty much. Not either that. The only exception is we have some people, their kids live in town. Parents were from someplace else, so the kids brought them to O'Neill.
Thank you.
And do you know what percentage you have of Medicaid right now?
20%. It's runs pretty close. 17 to 23 it runs. Stays pretty steady through the years. And what happened, most of our residents, most of it is people that come in, run out of money. We don't kick them out.
Okay.
Being rural, it's a little hard to do.
Other questions? Seeing none, thank you for your testimony.
Thank you.
Next proponent. Welcome.
Thank you, Chairman Clemens and members of the Appropriations Committee. Good afternoon. My name is Lisa Nielsen, Lisa-Nielsen. I'm the Vice President of Ray Brown and Associates, and that's a development company for long-term care facilities. In addition to my role as a developer, I'm also a shareholder in 4 assisted living facilities. O'Neill, the gentleman that just spoke, his facility in O'Neill, Ord, Gothenburg, and Doniphan. And all of these facilities were built with private money from local investors. And like many assisted living facilities in our state, they're small in size. They range from 25 to 65 apartments. The buildings are locally owned and governed, and they were developed out of consumer desire for a less restrictive alternative to nursing home care. They've been home to many people, and they play an integral role in supporting the local economies that they're in. Generally, the Medicaid person that we serve has lived in the community all their lives. They've worked hard and they've saved, but they have limited income and minimal assets. And unlike many facilities, we don't require that a person pay privately before they can come in, or pay privately for a certain number of years. If we're able to meet their needs, they're generally accepted for residency. Assisted living is required to provide for Medicaid residents a furnished private apartment, including all utilities, maintenance, transportation, 3 meals a day plus snacks, medication administration, and assistance with personal care 24 hours a day. In addition to these services, there are more Medicaid regulatory requirements than for our private pay residents. We have greater background checks for staff and more reporting requirements for resident status, reporting to their caseworkers. So our administrative cost is higher for our Medicaid resident than for our private pay resident. And last year, DHHS commissioned a rate study. I hesitate to mention that, but the study concluded that based on cost analysis, that the Medicaid portion of the 2022 waiver assisted living rate should have been $83.84 per day, rather than the actual payment of $59.38 per day. So that's the rate that we're getting right now, $59.38. This is a difference of $24.46 per day, or $8,928 per resident each year. Based on the department study, the facility, like the ones that I've mentioned, averaging 20 Medicaid residents, lost approximately $178,560 in 2022. The department rate study that was issued or completed in 2020, they used 2021 financial information from Nebraska assisted living providers to arrive at the recommended rate. And according to Social Security Administration, the cost of living increased by 5.9% in 2022, 8.7% so far in 2023. So according to inflation, the study that was commissioned in 2022 is now outdated, and the proposed rate is already behind by another 15%. For assisted living facilities to continue providing care to Medicaid recipients, the rate must be increased. As you're all aware, the labor market is much more challenging than ever, and the cost of doing business much greater. This is not a matter of it would be nice to have a reasonable Medicaid rate, but it's imperative the rate be increased so we can take proper care of ours. And just working with you, and thank you for taking time to hear my testimony today. And I'm happy to answer any questions.
Other questions? Senator Erdman?
Thank you, Senator Clements. Thank you for coming. So if they did a rate study and it's supposed to be $83 a day and they're paying you $59, why don't they pay you the $83? You know what the answer to that is?
I don't know. I would like to know.
We're going to try to find that out.
Yeah. Yeah.
That's crazy. Thank you.
Thank you.
Other questions? Do you know how many are on Medicaid and assisted living in Nebraska?
I don't have that
Do you know what
answer.
percentage your facilities run?
In our facilities, it ranges, depending on the location, from 10% to up to 45% Medicaid.
That's a big difference.
It is.
Very good. All right, thank you for your testimony.
Thank you.
Are there additional proponents for LB 131?
That's ridiculous.
Seeing none, is anyone here in opposition? Seeing none, is anyone here in the neutral capacity? Seeing none, Senator Dorn, you may close.
Well, I thank you very much. I thank you for a lot of the questions today, and I thank you for putting these all together at one time. It was quite a challenge on part of it, but it was also very nice to have different people that could comment on different things today here. If there's any questions, I sure would take them. Otherwise, thank you very much.
Any questions? Seeing none. We do have comments for the record on LB 131. We have 19 proponents, 1 opponent, none in the neutral. And that concludes the hearing for LB 131. And Senator Dorn is done for the day here. Our next bill will open the hearing for LB 149. Senator Jacobson.
Well, he is probably in a different state right now.
All right.
Because he has business with the federal bank board that he was supposed to be at all week and just had to be here for some votes.
All right, well, welcome.
We good?
Yes, go ahead, open.
Good afternoon, Chairman Clemens and members of the Appropriations Committee. My name is Joe Murray. That's Joemurray. And I am the legislative aide appearing here on behalf of Senator Jacobson from District 42. Senator Jacobson introduced LB 149 at the request of the Nebraska Hospital Association and his local hospital, Great Plains Health in North Platte. This bill is part of a package of bills brought on behalf of the Hospital Association to address the great need for specific level treatment beds, such as psychiatric and rehabilitation beds. Hospitals are struggling to move patients to their appropriate level of care, losing much needed bed space as these patients wait to be moved to the next level of care. This bill is one way in which it can help. Most importantly, LB 149 directs the Department of Health and Human Services to rebase their per diem rates paid to behavioral health providers providing inpatient care in psychiatric facilities, hospital-based psychiatric units, and psychiatric residential facilities. This simply requires rebasing the base amount using more recent claims data, cost reporting data, and other relevant reimbursement information. A rebasing of these behavioral health rates has not taken place since 1993. That's nearly 30 years. The bill also directs a similar rebasing of inpatient per diem rates for rehabilitative facilities and hospital-based rehabilitative units. As you can see from the language of the bill, the amount of the appropriation itself is not spelled out. In discussions with the department, we understand this rebasing can be done budget neutrally or with any rate increase that your committee includes with the budget. Even a budget neutral rate rebasing would be important to determine today's cost, rather than continuing to use 1993 figures. It is our hope then that with a more accurate recognition of today's cost to provide these specific services, we can stem the loss of psychiatric and rehabilitation beds across our state. Since I won't be closing, I believe we're going to hear from the department that they have some changes they want, and Senator Jacobson would certainly be open to those. And the judicial branch has also approached the senator asking that they be included in the language of this bill so that the rates that probation pays are equal to the rates paid by Medicaid. And Senator Jacobson would be agreeable to those if you decide to do it. Senator Jacobson also is baffled again by the bureaucratic math of HHS on its fiscal note. Roughly $500,000 per year for what is basically redoing a mathematical formula and then applying to what is already being done with the current formula. It seems excessive. I mean, there's almost $100,000 a year for one new employee. By legislative standards, that's a huge increase. And then maybe we need to be in the reconsider careers for rebasing consultants. They want $400,000 a year for a consultant. This seems excessive. Our tax dollars, the bureaucracy of appointing them. This is an important date to our budget language, and Senator Jacobson asked that it be included in the budget package as you move forward in the coming weeks. Thank you. This is an important date to our budget language, and Senator Jacobson asked that it be included in the budget package as you move forward in the coming weeks. Thank you, and there'll be others to answer questions.
Any questions? Seeing none. Did you say you're not staying to close?
No.
All right, thank you. First proponent for LB 149. Good afternoon.
Good afternoon, Chairman Clements, members of the Appropriations Committee. This is Jeff Francis, and I am Vice President of Finance and CFO for Methodist. As mentioned earlier, Senator Mike Jacobson introduced LB 149 at the request of the Nebraska Hospital. This is many bills submitted on behalf of NHA to support our hospitals. This particular legislation will move the reimbursement to healthcare facilities for patients needing psychiatric or rehabilitative services more in line with the cost to care for these patients. LB 149 would direct the Department of Health and Human Services to rebase the per diem rates paid to behavioral health providers when providing inpatient care in psychiatric facilities, hospital-based psychiatric units, and psychiatric residential facilities. The behavioral health rates have not been rebased since 1993, 30 years ago. A rebasing would update that amount to reflect recent claims data, cost report data, and other relevant reimbursement information. The bill would do the same for inpatient per diem rates for rehabilitative facilities and hospital-based rehabilitative units. It's my understanding that the department could rebase in a budget-neutral fashion, and if the committee would provide a rate increase, the rate increase could be incorporated. The rebasing would make a difference for aligning the reimbursement we receive closer to our cost to care for patients at the 20-bed behavioral health unit at Methodist Fremont Health and the 20 beds for inpatient rehabilitative services at Nebraska Methodist Hospital. In summary, I would ask that you include this bill language in the budget package that will be moved forward in the next few weeks. Thank you, and I'll take any questions.
Senator Dover.
Yeah, can you explain what rebasing means? I mean, my limited understanding would assume, and I'm sure it's incorrect, but you can correct me just so I know my starting point is that a base was established in 1993, and basically it was just that's your base point you're going to reference from, and then things are added based on that.
Correct, and hasn't been reflective of updated in cost, changes in care that would be provided in a more recent review with cost reports and related information.
Could you explain how changes in care would affect the base?
Could be additional costs associated with a higher nursing census to care for the psychiatric patients or for the rehabilitative supplies that would be required to take care of those patients in either of those settings.
Okay, thank you.
Mm-hmm.
Other questions? Can you explain how that, excuse me, Senator Armendariz.
Thank you. Thanks, Jeff. It's nice to see a friendly face today. Can you tell us, so for 20 years, not having that rebased, what that might mean to your health system in particular?
Yeah, over the last 30 years, that hasn't been rebased. What that does is it keeps expanding the difference between what it costs us to care for those patients versus what we receive through Medicaid on a per diem rate. And that rate continues to grow without a rebase.
So the gap keeps getting larger.
The gap does keep getting larger, yes.
Okay, I appreciate it.
And the comment is that it's revenue neutral. How is, or budget neutral, how has that happened? How can that be?
For us, what it would mean is that we would have a rebase, so we would get paid more in the psychiatric or the rehabilitative, and likely there would be an adjustment to some other types of services that are provided or covered through the same DHHS budget.
A reduction in something else.
Correct, unless there would be additional monies approved or passed through a budget from this committee.
Senator Lippincott.
Is this multiple locations?
This would be facilities throughout the state of Nebraska, yes.
All right. Senator Dover.
Just again, so as far as what you're saying is that if you get the increase because they're just budgeted so much that they would be forced then to cut someplace else?
That would be my interpretation, yes. I have not spoken with the department specifically about it, but there is such a difference between what we're getting paid on a per diem rate versus what our costs are because of not rebasing, that we would like it to at least address it for the psychiatric and inpatient rehabilitative settings.
Can you just use an example of, I mean, the numbers don't have to be relevant necessarily, but could you just tell me that if the base was done back then, it was this number, but if we rebase it, it would be at this number and how it might affect you?
Well, I know NHA has put out some information on it, and they had an example from one of the sister health systems where the base is at a little over $3,000, and their costs on a per diem for a per case basis was $6,700. So reimbursement was at 40% of the cost in that example.
So these are simply then asking us to adjust to the 6,700?
Up to, closer to that number, yes. I don't know if the actual rebates would get to that cost to provide it, because in most cases, Medicaid doesn't reimburse to cover total costs of services, but it would get closer.
Thank you.
Senator Armendariz?
Thank you. Thanks, Jeff. I don't know if you can share this broadly, but it'd be really important for the senators to understand how the health systems recover these losses if the state doesn't reimburse at the level of cost.
As explained in some other testimonies today, it really then becomes a burden onto the commercial payers that the rates continue to go up, because at the end of the day, we will have a very thin margin, and to the extent that the costs aren't covered from a governmental program that's becoming a larger portion of our of the care that we provide and the patients that we care for, it does then go on to the commercial rates and going on to the employers and the employees within the state of Nebraska.
Thank you.
All right. Other questions? Seeing none, thank you for your testimony.
Thank you.
Next proponent. Good afternoon.
Good afternoon. My name is Pat Connell, P-A-T-C-O-N-N-E-L-L, and I'm here on behalf of LB 149. I've been a longtime member of the Nebraska Hospital Association Public Policy Committee. I've probably been on that committee probably for 15, maybe 20 years now. I've also been a very active member with the Nebraska Association of Behavioral Health Care Organizations over the last 33 years. I've been president 4 times and served in a variety of different capacities. At one point in time, back in the 80s, I was the chief financial officer for St. Joe Center for Mental Health. And then in the early 1990s is where I was at the first rebasing conference that the state of Nebraska had. This was in about 1992. They hired a consultant. The consultant came in. They gave them a bunch of reports. The reports back then were called FA20s. FA20s were, I don't know whatever happened to them, but every hospital that had an inpatient program or an RTC had to produce annually this FA20 and swear under blood that this was accurate and complete. And this gave the department an understanding as to what the cost was for providing those services. So what happens over a period of time is the Joint Commission, who does our accreditation, adds standards on, and then also if the state of Nebraska revises its Medicaid regulations or licensing regulations, and sometimes those add cost. And so what has happened what happened was we had the director of HHS, who's long left the state, decided to have this rebasing. The first report that they got back based on our cost report said that the state would have to alter and increase our rates substantially. Well, that wasn't going to be acceptable because that's not budget neutral, but it portrayed the difference between cost and the rate. We went through 7 different renditions of that report, and somebody in the department gave us a copy of those reports. They were 36 inches tall for those 7 renditions of those reports. And finally, it's like Goldilocks and the 3 Bears. They came up with a report that was just right. Well, the rate matched what was there for budgeted dollars. What ended up happening was that was about 50 to 70% of the actual cost of what it was costing us on operating costs alone for providing that service. We seriously objected to that. We laid it out and said, this is going to decimate the mental health system over a period of years. By shortchanging to that, we're going to have to depend upon our med-surg hospital brethren. There's a whole bunch of providers that have closed their doors since 2000. And those programs used to be supported by these hospital inpatient programs because they wanted the patients, when they went to go home, we wanted continuity of care. And so that's why we were supporting these rural hospitals, rural mental health centers and et cetera. The reason this is sort of solely a problem of inpatient and RTCs is that we don't get mental health region dollars like the mental health centers do and et cetera. Our money comes from commercial insurance, Medicare, Medicaid, and some self-pay, and from time to time, maybe child welfare or juvenile justice, but it's a very small amount. So the director said, well, we're too late. This is June. The new budget year starts in July. We'll fix that in the future. We've been waiting 33 years for fixing this. So what the mental health community has done is we have commissioned reports on our own. I wish Senator Erdman was here because I would love to tell him about the cost methodology that we used. We gathered those FA20s. We turned them over to Simon Johnson, an accounting firm in Omaha. That's a national healthcare accounting firm. And they took those reports, and we've come before the legislature in the past and asked for some increases. Our typical increase is anywhere from 1.96% to about 2.3 or 2.4%. We are extremely grateful for the 15% rate increase we got last year because that's the difference between survival and closing our doors, at least on a temporary basis, because our costs were going up 20 to 20-some%. So the reason we're proposing this and the reason we want to move forward with this is we got to do an open and transparent process. Let's get the information on the table. Let's resume these FA20 reports. Let's see what it really costs us to provide inpatient and PRTF services, and then figure out a way to reimburse accordingly. And it's probably going to take some additional money, but you can't increase mental health services if you're not going to be, and nobody's going to open new programs when the cost difference between the rates and the costs are such a big spread. Sorry for running over. Thank you.
Okay, thank you.
I hope that's helpful.
Other questions? Senator Dover?
You might have already said this, but what is the current spread?
I'm sorry, what?
What would you consider an average of the current spread?
Oh, from discussion with my peers, it's still probably 50 to 70% of the reimbursement is our cost. Our reimbursement is 50 to 70% of our cost.
Right.
And it all depends upon which kind of a inpatient or PRTF program.
Right. Thank you.
Any question? Seeing none, thank you for your testimony.
Thank you. Appreciate the opportunity.
Next proponent.
Good afternoon again, members of the Appropriations, the highly esteemed Appropriations Committee. I am Jeremy Nordquist, Jeremy Nordquist, President of the Nebraska Hospital Association. Be real brief. Just want to, on the point of budget neutrality, we certainly would appreciate this being considered in your provider rate increase. I know you had hearings already this week on behavioral health. Certainly that is where we want to go. I think, when we talk to our hospital executives, obviously base rates and the issues we talked about earlier today were priority number one, but right behind that is behavioral health capacity because it is having other impacts on our hospitals. We started doing a report every month of how many patients are sitting in our hospitals unnecessarily. It ranges at any given time. It's a snapshot report between 250 and 290 patients. And a significant portion of those are behavioral health patients that we can't get placements for. So we need inpatient capacity. We need to support it. We need to nurture it. We need to create an environment where we preserve and even expand inpatient behavioral health capacity in the state. And it comes down to being able to operate. And for Medicaid patients, operating at those numbers are right. It's about a 50% loss right now because you go back to 1993, you make that your point in time. Well, your costs since 1993 have grown faster than the rate of increases provided through the state budget. So we're asking to make progress on that, but we also think the rebasing is important just to kind of reset the decks in terms of the costs of providing behavioral health care to make sure that the pie, however big you decide to make the pie, that the pie is distributed reflective of the costs of providing that care. So take any questions.
Any questions? Seeing none, thank you
Thank
for your
you.
testimony. Are there additional proponents for LB 149? Seeing none, is there anyone in opposition? Seeing none, is anyone here in the neutral capacity?
Don't feel like I can get away without answering questions about this.
All right. Good afternoon.
Good afternoon, Chairman Clements and members of the Appropriations Committee. My name is Dr. Kevin Bagley, Kevinbagley. I'm the Director of the Division of Medicaid and Long-Term Care within the Department of Health and Human Services. I'm here to testify in a neutral capacity for LB 149, which would require our division to annually rebase several services using the most recent Medicare cost report as its basis. LB 149 would bring a significant amount of new work to the division by requiring the department to rebase the following rates on an annual basis: inpatient psychiatric facilities, hospital-based psychiatric facilities, psychiatric residential treatment facilities, rehabilitative facilities, and hospital-based rehabilitative units. I want to take a second here to talk a little bit about what rebasing implies. As we've heard in previous testimonies, what it really reflects is an effort to evaluate the underlying basis on which we set a rate. So looking at things like the direct care cost components, the overhead cost components, if there's technology involved in certain services, looking at the relative risk of a service and what the implications for malpractice insurance might be. All of these factors come into play when we look at what rate should be set for a service. And so when we talk about a budget neutral rebase, what we're really saying is we take an amount of money spent on these services, and for sake of math, because I'm not ready to do a whole lot of really complicated math on the fly, if it's $1 million total that's paid for these services, we take that pie of $1 million and shuffle it up or down on a relative basis based on the new underlying basis developed in that rebase. So a budget neutral rebase implies increases in some service rates, but decreases in others to offset those increases. So when we talk about that as a budget neutral, I want to be clear, that doesn't change the size of the pie. It just shifts the relative size of individual service rates. Rebasing rates is more complex than simply applying a percentage increase or decrease to rates. It requires evaluating payment categories, like I mentioned, relative to each other and adjusting the basis for calculating those payment amounts. There is a substantial amount of analysis necessary. When Mr. Connell talked about 36 inches of paper in 1993, those cost reports have not gotten more simple or less complex in that amount of time. I can tell you, having worked with a lot of those in order to do some of this rebasing work, if you printed those all off today, it would probably be a lot more than 3 feet high. It would fill this desk 3 feet high, and you still wouldn't touch it. So it is a considerable amount of work. And part of that would also include incorporating those changes in that reimbursement methodology in new authority from our federal partners, as well as incorporating that into our capitation rates that we pay to our managed care plans in order to ensure that those changes are reflected in the payments that they make. Given the volume of work necessary and significant complexities involved in implementing a new rebasing process, the bill imposed deadline of July 1st, 2023 does not allow for the department to adequately do so by that date. We would not recommend an effective date for those newly rebased rates until at least July 1 of 2024 in order to incorporate the amount of time needed to really have that discussion with providers as well as our federal partners. The bill also requires the department to produce an annual report containing information regarding behavioral health bed capacity. This information would be incredibly valuable in identifying service gaps as well as providing better insight into service availability throughout the state. However, we would need to create some internal infrastructure and reporting instructions for providers in order to promulgate, and as well as promulgate regulations in order to have all of that information at our disposal. That also takes time. One other thing I'll mention is the bill requires this to be done on an annual basis. Given the amount of work and the fact that those underlying cost factors don't typically change dramatically from year to year, while sometimes they do, that's atypical. We would request more flexible language to the tune of something like once every 5 years, or at least once every 5 years.
So that's your time, but
That's
we're
my time.
interested in the department's information, so please continue.
So I will wrap it up quickly by just saying that we appreciate all of the opportunity to collaborate with partners across the state, with Senator Jacobson's office, in order to kind of have these conversations and really work through this. We recognize the need for improved behavioral health service delivery across the state. And so we want to be clear, these changes we're recommending are not in an effort to delay or put off, but rather to ensure that this gets done right in a way that's sustainable moving forward.
Other questions? Senator Dorn.
Thank you, Director Beck. Periodic basis. They don't require anything then?
If there is statute that does require it, we can follow that. So there are other bills, for example, in our critical access hospitals that this year would require that to be done on a periodic basis. That makes sense, frankly, for us to do. And we do that with relative periodicity, depending on the nature of the service. So we're supportive of doing those rebasing, whether it's in statute or not. Certainly doesn't require statutory language for us to do it.
My question will be, is it with a lot amongst your peers or whatever? Do other states do it more often, or how what do you hear from some of them?
It varies quite a bit. There is a significant amount of work associated with doing these types of rebasing. And so generally you will see this come about as a result of statute. And the reason why is because it often requires an increased appropriation in terms of resource to do the work. So if states don't have that resource readily available, there's usually some legislative action that has to take place in order to facilitate that.
Thank you.
Senator Armendariz.
Thank you. Thank you, Director, for being here. So the rebasing hasn't been done in 30 years. What do you think is an appropriate amount of time that we could set as a standard to rebase? Every 3 years, every 5 years?
So the language I think I might recommend would be at least once every 5 years. And I'll give a little bit of explanation as to that. The at least ensures that it has to be done at least that often. But it also gives us an opportunity to be flexible in years like the last several where we've seen dramatic shifts in costs. We may not want to use the previous year's costs to rebase rates for the first year of the pandemic. Or conversely, we may not want to take the last year of the pandemic's costs to be the basis for moving out of the pandemic rates. And so it would give us the flexibility from a statutory perspective to work with stakeholders in the community to say what does make sense. It also alleviates part of that resource burden on the state. But I think we're open to having a discussion as to what the industry and other stakeholders think makes sense.
Okay, so you're fairly new to your position, correct?
Yeah, I've been here about 2.5 years.
Yeah. So do you think putting it in statute would be a good motivator since it hasn't happened in 30 years. We want to actually put that in statute to make sure that it happens. And are you thinking that you want it at least every 5 years because it could benefit the state? Or would you do it at the direction of, say, providers that find that they're being underpaid again? Would you do it at the direction of them as well?
So I'm going to try and answer that in a couple ways. And feel free to follow up if I don't adequately answer that for you, Senator. I think whether or not it's in statute, we're supportive of doing these periodic rebases. The fact that it hasn't been done in 30 years, I don't know that I can speak to kind of the why or any of that, but it does make sense to reevaluate these. I think one of the barriers that states run into in doing that work is we do sometimes come to the conclusion that costs have outpaced appropriation. And that puts us as state agencies in a difficult position because we don't manage the purse string, right? That is the role of the legislature, to make those appropriations decisions. And so it puts us in a position that can be sometimes difficult in saying, we see here in the data that we're covering, say 50% of your costs, but we're not in a position to change what percentage of your costs are being covered short of an appropriation from our legislative partners. And so in that difficult spot of, I don't necessarily want to try and come and tell this committee how money should be spent. But at the same time, I think it's helpful to have that data so that everyone's starting from the same position and understands the current state of the market.
Yeah, I would say, speaking for myself, I would appreciate knowing with my eyes wide open.
Yes.
And not having blinders on. So I'd
And-
rather know exactly what it is instead of just kind of letting it sit there without looking at it.
And I agree. I would prefer to err on the side of transparency. The reason I share that is really just that is, I think, the sensitivity that you find with a lot of state agencies nationwide, right? Is we can't necessarily just come to a legislative body and say, you're going to have to pay more. But starting with kind of eyes wide open and being clear about the current state of the market, having this in statute allows for everyone to kind of come together and say, we see what is going on, and we can make decisions based on that.
Thank you.
Yeah, thank you.
Senator Bouchard.
Thank you for being here.
Thank you.
I may be way off on this. Can you correct me? Would TANF funds be able to be utilized for any shortfall that would come should you find that in rebasing there needs an additional amount of dollars to support this type of aid?
So I will caveat this with saying I am not an expert on TANF funding. That being said, generally speaking, we're not able to leverage federal funds to offset our Medicaid dollars, because that ends up kind of being a position where we use federal funds to pull down federal funds. And so we wouldn't likely be able to do that. Whether that could be done completely separately from Medicaid reimbursement, I don't know. I would probably have to defer to someone who has more expertise on TANF funding requirements.
Okay, I'm not an expert either, so appreciate your candor there. The one other question I have is picking up with what Senator Armendariz was saying. If the legislature were to know that a rebasing were to be happening within the next couple of years, would it work for us to set aside a certain portion of dollars that then, should that rebasing result in an additional need, that we would have set some dollars aside for then you to be able to utilize for that need?
You know, I think I'm not sure
Okay.
the best way to answer that, but I think what I would say is we would be happy to sit down with anyone here in this committee, as well as stakeholders in the community, to try and work through what makes the most sense in terms of planning for the future.
Okay, thank you.
Other questions? Seeing none, Thank you for your testimony.
Thank you.
That is a neutral capacity, I believe. Yeah.
Wait a minute.
Anyone else in the neutral capacity? Seeing none, he is not going to close. So we have, for LB 149, we have 6 position comments, 6 proponents, no opponents, and none neutral. That concludes the hearing for LB 149. We'll open the hearing for LB 525. Senator Fredrickson. Good afternoon.
Good afternoon. All right. Good afternoon, Chair Clements and members of the Appropriations Committee. I'm John Fredrickson, JOHN, I represent District 20, which is in Central West Omaha, and I'm happy to be here today to introduce LB 525, which provides a 15% increase in provider rates for psychiatric diagnostic evaluation and for evaluation and medication management follow-up visit services. It was brought to my attention by substance use treatment and mental health providers that a critical service paid for by Medicaid was at an extremely low rate, making it more and more difficult to provide the service. That service, which enables providers to conduct a diagnostic assessment evaluation and to monitor and adjust medications, is known as psychiatric diagnostic evaluation and management, or more generally known as just medication management. I have passed out the service definition for you today for additional information. A medication prescribing healthcare professional, so like an APRN or a psychiatrist or physician assistant, must be the one directing this care, which can make it more costly than just talk therapy. This service is provided in both inpatient and outpatient settings, and it allows more patients to be moved out of expensive inpatient settings while also allowing them to receive continued support and as their conditions improve. I know as a mental health provider myself how important psychiatric care and follow-up services are to an individual's recovery and management. Appropriate provider rates are necessary to allow more individuals to be served, especially in our ongoing mental health care crisis. I also bring to you today AM 909, which also appropriates dollars to the Supreme Court to allow for increased provider rates for these same services. The Administrative Office of the Courts asked me to bring this amendment to ensure we would not have different rates for DHHS than for the Supreme Court. My staff followed up with the Fiscal Office to ensure we were proceeding as per usual course with this amendment. I also want to make mention to the fiscal note. So there has been a little bit of confusion with that. So the figures included are substantially higher than the actual cost. So this is because there was confusion about the intent of what would actually be covered in this bill and who would be covered under this bill. So multiple codes cover the service of psychiatric diagnostic evaluation. But our intention with this legislation is to cover the initial diagnostic interview and follow up with established patients afterwards. There are actually only 6 codes that we intended to cover with this legislation. So providers covered include medical doctors, doctors of osteopathic medicine, physician assistants, and advanced practice registered nurses. So my staff has been in contact with the Fiscal Office, and Fiscal is getting new estimates from DHHS based on the intent of this bill. So they have that request up to DHHS currently. So we'll continue to work with them, and we'll hopefully get that worked out as quickly as possible. We have others here today who will testify as to the details of the service and the costs associated with it, and they will talk in more detail about who this will actually cover. With that, I'd be glad to answer any questions you may have.
Other questions? Seeing none, will you stay to close?
I will be here to close, yes.
All right, thank you, Senator.
Thank you.
We'll welcome first proponent for LB 525. Good afternoon.
Good afternoon, Senator Clements, members of the Appropriations Committee. My name is Tammy Lewis Arndt, TAMI LEWIS-AHRENDT. I'm the Executive Vice President and COO of Centerpoint, a private nonprofit corporation doing business in Nebraska with service locations in Lincoln and Omaha. I'm here today to testify on behalf of Centerpoint and the Nebraska Association of Behavioral Health Organizations in support of LB 525. LB 525 increases rates by 15% for the services that are identified as psychiatric, diagnostic, evaluation management, or simply put, medication management. These services are provided in outpatient settings where the prescriber conducts an evaluation of the individual's need for psychotropic medications, provisions of prescription, and ensures an ongoing medical monitoring of these medications. These appointments are provided by a prescriber, a doctor, a PA, nurse practitioner, or DO, and require the support of a nurse or medical assistant who check vitals, review the overall health of the individual receiving the service. Medication management services are critical to keeping individuals out of hospitals, emergency rooms, corrections, and other law enforcement encounters by ensuring they have access to effective medications and that those medications are working, or by providing an adjustment to those medications if they aren't. Because these appointments are related to the prescribing of medication, they must be provided by high-level professionals. The current Medicaid rate for this service falls short of covering the cost of the appointment by 18 to 20% at Centerpoint. This service requires not only provider time, but includes nursing support, coordination of care, and access to medications, medication education, and assessment of other health-related issues necessary to ensure safe and effective care for the people we serve. Provider time plus these added and necessary expenses means a loss on each and every service we provide. In this array, the requested 15% rate increase would allow us to further bridge the gap between our costs and the reimbursement. We've appreciated the support of the legislature over the last few years. Most recently, passing a 15% rate increase. Our president, please pass the emergency funding increase of 15% for medication management so we do not have to turn away people for the life-saving care and access to the medications that allows them to live their lives. Thank you for your consideration, time, and commitment to serving Nebraskans. I'm happy to answer any questions I can.
Other questions from the committee? Senator Armendariz.
Thank you. Thank you for being here. Can you tell me when you have a patient, an ongoing patient that regularly is seen, how many months does he or she have that?
Sure, it would depend on the individual and the medication, the severity and complexity of the issue that's being treated. Mental illness is oftentimes a chronic issue like heart disease and diabetes and takes ongoing care. So a number of the patients that we serve at Centerpoint, we've been serving for the last, well, I've been there 15 years. And I know there are folks that have been going to see our psych providers for at least that long. Oftentimes those medications diminish in effectiveness, and so they have to start new medications, which takes more frequent visits until they're stable, and then maybe they're seen once every 6 months to validate and ensure those medications are still functional. So initially, if somebody comes in for a diagnostic appointment, they may be seen that time, and then maybe a 2 to 4 week follow-up depending on the medication, and then maybe a 2 to 4 week follow-up after that, and then it might be 6 months before they need to be seen again if that medication is deemed effective for them. If they can call and say it's not working or I'm having side effects, just like any medication that we take, and be seen sooner if needed. Does that answer your question?
So if you're trying to regulate the medication right off, do you have them come in each time, or do you just bump it up or bump it down over the phone?
We try to see them in person. We try to have them come in for evaluation. I guess it would depend on what they're reporting, and I'm not a clinician, so this is based on my knowledge of working with the staff that we work with and seeing the frequency of visits, but it would depend on the side effect that was being reported, but typically we try to see them if they're complaining that the medication isn't effective or that they're experiencing something negative, if they're asking for a titration or a change to the medication.
Okay, thanks.
Other questions? Excuse me. Let's see. Just a minute.
No worries.
Was the intent of this for medical management only or also when other services are provided?
My understanding is that the intent is just for the diagnostic interview and then the 5 visit codes that follow. So it's a limited array of visit codes related to the evaluation and management of medication support for psychotropic medications.
So psychotropics are for epilepsy, sleeping disorders. Is that supposed to
I'm being told that are codes for epilepsy and sleeping disorders included?
My understanding is that this is just for mental health provision. So we don't contemplate that including epilepsy unless it's an individual who has a co-occurring issue. So they may have both a mental health concern and epilepsy, in which case they may be treated in the same appointment because the medications may encounter with each other, but they wouldn't be exclusive for an individual who has epilepsy, to my understanding.
Yeah, being told the codes are the same and the fiscal note is based on the language of the bill, which our analyst may need to fine tune, or the bill may need to be fine tuned to carve out things that are being included in the fiscal note.
For sure.
I had a question about, do you know with CenterPoint, what % of Medicaid patients you have?
Yeah, currently in our psychiatric programming, so the program that is impacted by this specific bill, we have about 61% Medicaid.
And then there's some Medicare?
We do have some Medicare,
And then
it's
some private?
some private and some Division of Behavioral Health. So those region paid folks.
And this would be the Medicaid portion that this bill would cover?
Yes, sir.
All right. Other
Yeah.
questions?
Just to clarify, Medicaid pays these services differently than Division of Behavioral Health, and that's where a lot of the disparity comes in. The Division of Behavioral Health has just a set rate for medication management, and it's paid on a 15-minute increment. So if an appointment is 15 minutes, it's 1/4 of that rate, or it's the rate. And then if it goes longer, it's times 15-minute increments, where Medicaid pays on a CPT code basis. So they're coded services billed not necessarily based on time, but on severity and complexity of the services provided within that appointment. So that's sort of where Medicaid gets out of proportion compared to other payers because of how those CPT codes work.
All right. That sounds complicated.
Sorry if I made it overly complicated.
No. The analyst says it is.
It is, yeah.
Seeing no other questions, thank you for your
Thank
testimony.
you.
Are there other proponents for LB 525?
Hello,
Welcome.
thank you for having me. Good afternoon, Chairperson Clements and members of the Appropriations Committee. My name is Heather Nielsen, HeatherNielsen. I serve as the Medical Director at Lutheran Family Services. Today I'm testifying on behalf of LFS in support of LB 525. I want to say we're grateful for Senator Fredrickson's leadership on this issue and appreciate the Appropriation Committee's longstanding commitment to providers across the state as they work to serve some of the most vulnerable Nebraskans. Since 1892, LFS has served children and families, beginning as orphanages in Fremont and Omaha, has now become one of the largest nonprofit health and human services agencies in the state, with locations across the state of Nebraska, as well as an office in Council Bluffs, Iowa. As the needs of the individuals, families, and communities have changed over the years, so have our programs. We provide comprehensive behavioral services for children, families, and special populations, which includes veterans and refugees. Our psychiatric medication management teams provide services out of offices located in Lincoln, Omaha, and Fremont at this time. Each of the core treatment teams within this program is comprised of one psychiatric prescriber and a medical assistant or licensed practical nurse. Both of these individuals possess specialty expertise required for the populations we serve. Those populations are largely comprised of persons with complex treatment needs, including those with severe persistent mental illness, substance use disorders, dual diagnoses, and mental health board commitments. This service provision requires not only psychiatric assessment, prescription of psychotropic medications, and monitoring over time, but also a significant amount of coordination of care, psychoeducation, and support for the individuals and families to ensure that they're understanding the process needed to access and navigate the system adequately. Over 61% of the clients seeking services from LFS utilize Medicaid funding, and the expansion of Medicaid has certainly served to improve access to care for individuals and families within our communities. Unfortunately, that reimbursement doesn't entirely cover the costs of service provision. We're now consistently seeing a six-figure loss in our psychiatric medication management program, which we mitigate by conducting fundraising and donations, as well as limiting the number of clients to whom we can provide services at times, unfortunately. Lack of access to psychiatric medication management services can lead to serious health and social impacts for individuals, families, and communities at large. The lack of adequate reimbursement makes it difficult to build and maintain capacity within the specialty medical program at LFS, where we strive to ensure that all community members are served in a person-centered, team-based, and holistic health model of care. To sufficiently ensure that LFS can meet the growing needs of Nebraskans, an 18 to 20% reimbursement rate would be needed. The 15% increase proposed in LB 525 would make a significant impact on the financial stress that our providers face and ensure the continued ability to serve Nebraskans who are the most vulnerable. I agree with the last testimony that this decreases hospitalizations and unnecessary use of higher levels of care. I'd like you to please incorporate LB 525 into this year's budget package, and I'd be happy to answer any questions.
Other questions?
Can I offer, I'm sorry, I could speak to the CBT coding a bit if you wanted.
I have one question first. Do you know what percentage of Medicaid you provide?
61%.
All right. And then, yes, you're welcome to speak to the codes.
Okay, so the codes that we're talking about that go across the spectrum are called evaluation and management codes, or E&M. And those are actually the same CPT codes, the numbers for each one, that are utilized across a number of medical services for follow-up for established patients. So it's based on medical decision-making and or time of care spent with the client. It's not limited to psychiatric practices or provision of psychiatric services. So I'm assuming that the wording in the bill must speak to the practitioner who's providing it or the location of the service. Does that make sense?
My understanding is the codes to psychiatric care, so we can't isolate the psychiatric.
Right. Our understanding is the code is for both psychiatric and other types of care, and it's hard for us to isolate the costs separately,
Okay,
projected.
that makes
So the
sense.
fiscal note shows more than the.
Right, so the
intent.
fiscal note is really more than what the actual cost would be.
The intent, but the language is broad.
Oh, okay, right. The language is broad, and it's not sure. We'll have to see if the senator can work on that.
Well, in the intake code or the PD with medical services, that's specific to psychiatry. So it's just the E&M codes that you're going to need to clarify.
That helps.
Good.
That helps. Thank you for your testimony.
Thank you.
Did I miss any questions? No. Other proponents?
Good afternoon. My name is Pat Connell, P-A-T-C-O-N-N-E-L-L. I'm here as a proponent for LB 525. I've been asked to speak on behalf of Boys Town National Research Hospital, and the Nebraska Hospital Association. We first of all would like to thank the senator for introducing this bill. I just would like to just put this into some sort of real life context is what's going on here. About 20 years ago, and I'm going to do it from the perspective of Boys Town. About 20 years ago, Boys Town was having children in our RTC and our skilled our family homes and et cetera, and they would be returning to their home community. And we would, and if they were on psychotropic medications, we would try to get an appointment with a psychiatrist back in the rural area. And what we found is, well, first of all, there's a severe shortage of child psychiatrists. But when we call them and it was their kid in the first place, sometimes it's like 6 to 8 to 10 to 12 months away. You can't do that with psychotropic medications to children. You got to have that follow-up because their bodies are changing, they're growing. So I went to our leadership at the hospital, and then we went to our board of directors and said, we have to do something about this as Boys Town. We have to figure out a way of creating that continuity of care. And so I got permission. In my old job, I was the vice president of behavioral health. This started about 20 years ago. Started recruiting child psychiatrists. Got them from all over the country. And we now have the largest number of clinical child psychiatrists in the Midwest. Is in Omaha, Nebraska at Boys Town. Now, the thing that we're trying to do here is that we're trying to do two things. One is we get referrals from all over the state of kids that have been put on multiple psychotropic medications by family practice doctors, pediatricians, other people that may not have as much experience as a child psychiatrist. So we have gotten at least 600 kids that have been referred to us by Health and Human Services that are on these medications, and we take them off the medications, we evaluate them, and we recommend back. And in the vast majority of cases, they're on substantially less medications when they leave. Now, we still have that problem with what do we do with these kids that are being discharged from Boys Town and they're going back to their home community? In Omaha, it's a pretty simple deal. They just drive out to Boys Town or Boys rural, it's a problem. And it's in a lot of locations. And like, for instance, we're out talking to Box Butte Hospital. We've been out to talk to Scottsbluff Hospital in North Platte, Sydney, all these areas where they're underserved and the hospitals are very much welcoming us there. Now, let's talk about the economic realities. Right now, the E&M codes that are for that evaluation and management are, I truly, if I did a cost report today, I would say that probably about 40% of what it actual subsidized program. It's more than 6, but we see it as a very valuable fix for the continuity of care. We would like the codes to be high enough that we could get those doctors that are on in those rural areas to take our patients, as well as we can provide telehealth services. So I hope you keep this conversation inside here. I don't want anybody getting mad out in the rural areas, but it's reality. We need to fix these codes so we get more people that are willing to see Medicaid patients. And then we can hopefully will improve care for our kids. So that's what I want to offer today, and that puts this into context. We don't think this is going to fix it. 15% is not going to fix it, but it's going to go a ways towards reducing the amount that we have to go back and subsidize this every year. Thank you.
Are there any questions? Saying none. Excuse me. If we were going to do clinical rates, would that include these codes?
Yes. Yeah, these would be the same 6 or 9 EMN codes that relate to what psychiatrists do, DOs do, APRNs do. I think those are, and PAs do. There's a few PAs, and that's their evaluation of these of medications.
Does that answer it? Thank you.
Thank you. Appreciate it.
Thank you for your testimony. Are there any other proponents for LB 525? Is anyone here in opposition? Is anyone here in the neutral capacity? Seeing none, Senator, you may close.
All right. First of all, I just want to thank all the testifiers for being here today, and I also want to thank the committee. I know this is the last hearing of the day, so I appreciate you all asking questions and being engaged in this discussion. So a couple of things I wanted to address. So I know Chair Clements, you had a couple of questions about the what was actually reimbursable on this. So there was some initial confusion with the way the bill was written. My office has been in contact with the fiscal office. We're working with them on that. So this is only supposed to actually cover 6 codes. And so those 6 codes have been sent to DHHS. They're providing updated information on that. So as soon as we have an updated number on that and an updated estimate from fiscal, that will hopefully provide some clarity on that, sort of where that lies as well. The last testifier kind of mentioned, it's interesting because a lot of times we think about, these services being provided obviously on an in-person basis, but, telehealth and telemedicine, I think, is going to be a key component for a lot of this as well, especially with behavioral health. And, we see this a lot, especially in rural parts of the state where we do have a lack of providers and resources available. So, kind of a theme you'll probably notice with me this year is telehealth. I prioritized a Senator Brewer bill about telehealth. So I think it's a great way to sort of be able to deliver services throughout the state and across the state and to provide that to Nebraskans. So with that, I would be happy to answer any additional questions the committee might have.
Any other questions?
So if we were to go ahead and send their dollars across the board, would they still collect more on top with these?
The question is, if we would go with the increase that Senator Dorn is requesting, would this also want to be an additional 15% increase?
I would need to familiarize myself with the increase that Senator Dorn is.
We'll have to see about coordinating the different bills.
You don't
And I think the fiscal office, that's a question that maybe they can answer.
Absolutely, and we'd be happy to work with you and Senator Dorn on that to sort of figure out what
Continue
makes.
to work with them. There's some confusion about the details of the codes and what's covered. So, seeing no other questions?
All right.
Thank you, Senator.
Thank you very much.
We do have comments on LB 525. Position comments, we have 16 proponents, no opponents, and none in the neutral capacity. That concludes the hearing for LB 525, and that concludes our hearings for today.